You can always go back and watch the recording later if you need to. That is available to you. Even if you're live, you don't have to record your attendance multiple times, but these lectures are here for you to go back and watch as often as you need to. So I want to start off, a lot of people, you guys are doing a fantastic job of keeping up with your tests. Did give you 2 weeks extension on module 1 because the world can't figure out if it's going to end or not. And we've just been getting hammered with a whole bunch of stuff. So you do still have time. However, I want to stress that the class itself is not going to slow down 2 weeks. All right, we're still going to move into module 2. In fact, that's what tonight's lecture is the first night of module 2. So we're going to be continuing to press on. So I don't want you to think that, if you got 2 weeks and you can get it done in 2 more days or whatever, then do that. Don't just sit on it. But it is there. That extension is there if you need it. Some people, I will send out emails to you, but some people haven't taken a single test yet. So I want to make sure that if there's something wrong, if for some reason you still can't access Canvas or something like that, we get that hammered out, because with us going into the second module now, you're something to the tune of 7 or 8 chapters plus the discussion plus the module behind. And it gets really hard to keep up when you fall that far back. So we'll work on it. Like I said, you have time, just not a lot. But anyway, so without further ado, this lecture will not take too terribly long. Even though it's like 130, 140 slides, we're going to be skipping through a lot of them because this is stuff that you're going to be going over when you come to your boot camp. But I want to stress that I know that the chapter is long, so I gave you 2 nights worth of class to do the chapter, even though the lecture is not going to take that long. This is where you start to earn your paycheck as an EMT. Everything that we do is based off of the patient assessment. So before we even bother start to learning anything about, what do we do for a heart attack? What do we do for trauma and stuff like that? We have to first figure out how we're going to structure our calls. Everything is systematic. You need to think about it. You guys are the badasses, right? You're the ones that show up when somebody's world is falling apart. They call 911 because they were in a car wreck, or their chest hurts and they don't know why or whatever. And sometimes the scenes can be really gruesome. A buddy of mine, he's he's a paramedic for Acadian. He's actually going to be one of our instructors. He had a call the other day to just start his shift, and it looked like a scene from It. There was blood everywhere, blood all over the floor, broken glass, table was broken and busted up. He sent me a couple pictures of the scene. It was pretty gnarly. And what do you do when you walk into that? Because, like we learned in the first 2 chapters, we're human too. We freak out when we see things go wrong. We're not superhuman. We don't have super strength or some crazy lack of ability to get stressed and that kind of thing. So what do you do when you run into those kind of calls? You fall back on your patient assessment. Everything that we do falls under this. This is what allows us to provide the right level of care and give the right treatments that we need to, no matter what we see in front of us. All right, it may be something as simple as a stub toe where you're in your mind, you're rolling your eyes because, oh my God, somebody called 911 for this. Or you could be walking into a murder scene, and a gruesome one at that. So you don't know what you're going to face, but your assessment's always going to be the same. And as long as you follow this approach to patient care, you're going to treat your life threats. You're going to make sure you're safe. You're going to give the right treatments or withhold the wrong treatments that would normally go. Because sometimes like somebody has a heart attack, everybody jumps on nitro, but there's a lot of reasons not to give it. And if you don't do a good assessment, you tend not to find those things. You may give the wrong medication and do more harm. So that's what we're going to be covering up tonight. Let's get the introduction stuff out of the way. All right. Again, I could harp all night on how much this stuff matters. I need you guys, if you haven't already, go into Canvas, and on the left-hand side, there's a a files link. If you click on that link, it will bring up, you'll have an option to go into the class files, and there will be all of your assessment checklists will be there. You'll have the ones for your individual skills, and you're going to have the one for your trauma assessment, your medical assessment. Get those and memorize them verbatim in order, like you memorize your name and address. All right, we're going to be kind of nitpicking at it as we go through the class, but I really need, by the time we get to boot camp, if you walk in the room, I'm like, tell me your scene size up. All right, and then you can just rattle it off to me like it's nobody's business. Or I may be able to say, all right, tell you what, you're relieving an EMT who the last thing he did was check the blood pressure. What's your next step? That kind of thing. And you can immediately go, okay, well, the next thing after that would be this. It's not just to get you through your hands-on. It's not just to get you through the boot camp. A lot of your registry questions are going to be based on that. You're going to have to know how your assessment flows to know what the right answer is. You're going to have to know where you are in your assessment to know what the right answer is, because you may get a bunch of questions that are scenarios and it'll say, this is what you see in front of you, and these are the vital signs, and there's an EMT that just did this. What's next? And you're going to have 4 options, and all 4 of those will be in your assessment. They're things that you would do, but only one of them is next, that kind of thing. So learn it, read it every day, do something like that. We're going to kind of talk about the overview of it tonight, and we will get more and more into it as we go. No, your patient assessment does not treat your patients. And I'm going to show you how we kind of go back and forth between the assessment and our treatment options. But you can't really give treatment confidently if you don't get all this stuff done. So it's extremely important, all right? You have to master the patient assessment process, not just at your level, but even the EMRs. In fact, Justin is teaching the EMR class tonight. They're going over the exact same thing. So if you don't get it from this chapter, try listening to the EMR one. A lot of the assessment is the same. It's what you can do with it that varies based on your level. But you're going to use a patient assessment to some degree in every encounter. Obviously, sometimes you may, depending on what the call is, you may not be able to do everything. If your patient's unconscious and by himself, there's nobody to ask the sample history to, then you can't get sample. But you can at least consider it, right? You can consider C-spine even on a medical call. No, you're not going to put a collar on somebody. But if you look at your medical assessment, you'll see that it says consider C-spine. Can anybody tell me why that would be an issue? What would be a reason why you need to consider C-spine during a medical call? Right, we use it for spine and neck problems, but if it's a medical call, that's not trauma. Does that mean that medical will never involve trauma? No. So a good example of this, actually, the last time I was hit from behind was because the guy behind me had a seizure. And he had a seizure while he was driving down the road. So he smacked into me. I always get out to make sure the other person's okay before I even bother looking at damage to the truck or anything like that. And I see him in his car seat, in his driver's seat. He's still actively seizing. So that was very much a medical call, right? But because he was seizing at 40 miles an hour down the road, that was also trauma. That wasn't a fun call. I wasn't on duty or anything. I didn't have anything with me. So I couldn't really do a whole bunch, but I mean, you'll see there's a little bit you can do as an EMT. CPR, depending, right? If it's traumatic CPR, if it's a traumatic arrest, and sometimes, yeah, you may have to do that. Usually CPR is medical, but you can't rule it out. What if somebody had a heart attack driving down the road? So there's 5 main parts to your assessment. You have your scene size up, which will always come first. That has your BSI, which is body substance isolation. Your gloves, your mask, gown, goggles, hazmat suit, whatever it is you need to wear for your call. You have where you paint the picture of what you're dealing with. That's where you find out how many patients you've got. Are you enough for the patients you've got? Are you enough for the scene? Is the environment hazardous to you? Do you need a hazmat crew? Do you need more paramedics? That kind of thing. So all that stuff is done in your scene size up. Your primary assessment is your first Contact with the patient, that's basically where you're going to go through and make sure that all your life threats are taken care of. So this is, if you've ever heard of checking your ABCs, your airway, breathing, and circulation, that's where this happens at. All right, and that's a head to toe thing. Don't get yourself wrapped into only looking at the head and the carotid artery or something. So yeah, checking your airway and your breathing happens at the head, but you're also checking for hemorrhages, right? So you want to make sure that in this part, you're looking at the whole body, but you're not worried about the paper cuts. You're not worried about the broken bones. You're not worried about any of that. No matter how gnarly it looks, you're only worried about ABC, which is airway, breathing, circulation. The circulation is, do they have a pulse, and is it staying inside of them? So if it's hemorrhaging, like say they lost their foot, you'll take care of the hemorrhage at this point. But all the other bleeds that aren't an immediate life threat, you'll skip. Your history taking, they consider its own section of the assessment, mainly because you can take it out. All right, if there's nobody to ask questions about the patient to, then you don't need the history, because what are you gonna do, right? So if somebody's driving by themselves and they get into a car wreck, they're unconscious. You can't. There's nobody to ask. But I like to make that part of the secondary assessment. So I put that in there with their vital signs. I put that in there with their head to toe. If you're dealing with trauma, when we get to that point, you can and the reason I do that is because you'll see that it says that you can rearrange the assessment in order, or the order of it if you want to. I don't want you to get mixed up in that. Your scene size up always comes first. Your primary assessment always comes right after that, before anything else. Then it's your secondary assessment, and what's inside the secondary assessment, that's what you can rearrange. All right. So if it's critical and you need to move them, do a quick head to toe so you know what you're moving, right? You don't want to roll somebody with a broken hip. You got to take the time to take a look for that. If they're not critical, or if they're not, unstable or dying in front of you, and you've got time to take a history and vital signs, you can kind of move those up the list. That's okay. And then your reassessment. Go ahead and get the numbers 5 and 15 locked into your head now. What that is how often you're going to reassess. You reassess your interventions, anything you did in the primary. You reassess your vital signs, any of that stuff. You reassess. You can even consider reassessing your scene size up for your safety, to make sure to put that in there. But if it's an unstable patient, which means they might take a turn for the worse and dying, there's going to be some different things that we say. If you see this, they are automatically a critical patient. That's every 5 minutes. All right, because if something changes, we want to see that faster. All right, if they are stable, which I'm not going to give you a stable patient in training. I want you guys to get used to unstable patients, but in your real career, it might be 80 to 90% of your calls are stable patients who don't really need a whole lot of care. That's every 15 minutes. All right, so 5 and 15. Just remember that. Yeah, if you want to do 10, you can. You're not going to go wrong with that. But for testing purposes, if you hear it in the boot camp, it's 5 or 15. If you see it on a test, it's 5 or 15. If you do it every 10, you're not hurting them by checking more often. Rarely does one sign or symptom show you the patient's status or underlying problem. Know this difference. This actually was one of my registry questions, and there was nothing in that question to show me what they were asking. So a symptom is something you can't see. All right, that's subjective. If somebody tells you that their stomach's hurting or their chest is hurting, that's a symptom. Any kind of body process that's going on, you can't see. Say like an elevated heart rate. That's probably a bad example. We'll say lower blood pressure or higher blood pressure. Those are symptoms. They're not signs. You can't see it from across the room. All right. If they've lost some blood, all right, say internal blood, and now they're hypoxic, that's a symptom. A sign is something you can see. So if we'll use a heart patient. Let's say you walk up to somebody, they tell you their chest is hurting and they're sweating, which can anybody tell me what the medical term for sweating is? It starts with a D.
Diaphoretic.
Diaphoretic. So if you walk up to a patient and they're diaphoretic, that would be a sign, right? Because you can see that. If somebody is COPD and they're struggling to breathe, you see them in the tripod position, that's a sign. Um, Only 2 letters off. It's not too bad. But you can kind of get the idea of what I'm saying. A sign is just like seeing a stop sign. You can see it. So if you get a question that says, which of the following is a sign of a heart attack? And you read 4 options and they're all to do with a heart attack, but only one of them you can see. All right, that's the kind of questions you're going to get in the registry. It's the kind of questions you're probably going to get them on chapter tests and stuff like that. So just pay attention to the wording of your questions. All right, so let's talk about scene size up. This is your first thing that you do, and it actually starts with dispatch. All right, the minute you get a call, you can kind of get an idea. All right, well, this is going to be a car wreck, so I'm expecting trauma. And you can be thinking about the different things that you may deal with when you get to that scene. It could be anything from traffic control. You may go ahead and want to get the cops out. It could be, if it's 2 or 3 cars, if they tell you there's 2 or 3 cars, you're probably going to want some wreckers, the fire department. If there's entrapment, you're definitely going to want the fire department, that kind of thing. These are things that you're going to want to consider in your scene size up, because when we talk about additional resources, it's not just necessarily do you need more ambulances, even though that is very common, right? You want to try to get 1 ambulance per patient. There's a way for them to double that up if they need to, but if you can avoid it, avoid it. But it's not just that, right? If you need a hazmat team because it was an 18-wheeler spill, then consider that. Situational awareness is necessary through the entire call to ensure safety. Just because you start a call and we tell you that the scene is safe doesn't mean it's going to stay safe. So pay attention to cues from your evaluator, your instructor. If we tell you something that makes it sound like it might be a no longer safe situation, you have to go back and correct that. Or it's either something you can mitigate, or you may have to vacate. You may have to grab your patient and leave. But you only do patient care as an EMT in a safe situation. I realize fire departments, you guys have to kind of color outside the lines on that one. But even then, you're still taking the same approach, right? You don't go into a structure fire to do patient care with the building burning down around you. You don't go in without your gear on, that kind of thing. So yeah, it may be a dangerous situation, but you have mitigation things in place. Same thing as an EMT. Situation awareness is paying attention to the conditions and people around you at all times. So, like I said, some things may change. You may walk into a room for somebody unconscious, seems safe because person's unconscious, right? There's a gun sitting next to him. Is the scene suddenly unsafe because a gun is sitting there?
No.
Yes, yes, the scene is unsafe because there's a gun beside the patient. Even though he's unconscious, he might be playing it if he's unconscious.
Okay. All right, good. So this is a I don't know if I made this a discussion question or not. I need to though, because this is a good one. So if you let's paint this as a scenario. You come into a house, grandmother has fallen down the basement stairs. She's laying at the bottom of the stairs, unconscious, and we're just going to place a weapon of your choice. Doesn't matter. It could be a gun, could be a knife, whatever. It's right on the floor next to her. Can you approach that patient? Is the scene safe for you to approach?
No, the scene is not safe.
Okay, so we got a no. Anybody disagree? Got 2 no's. Anybody in the house willing to approach this patient?
I disagree.
Okay.
I'm going
all right,
to approach with caution.
approach with caution. Okay, that's a good one. So here's the thing: when we deal with unsafe
If
situations, you have
PD needs to be called in, I will call PD to join me if it becomes like that. That's when PD comes in. But I'll
okay,
be careful of the patient.
so that's an option. All right, good. Yeah, I'd like to get people to think outside the box. That's really good here. This is something that they never really went into it in school with us. We were always just taught you see a threat, you run away, but that's not always the case, right? If the lady is unconscious on the floor, that's whatever happened. That's a life threat, right? She's unconscious and we don't know anything. You might be getting down there and doing CPR or giving her sugar or who knows. Um, but that's a major thing. So we know we need to get to her. and we have a threat, but we don't have an unsafe scene. So yeah, there's a weapon there. And I may give you scenarios like this to kind of help get you into this right mindset. Someone may be inside. All right. Try not to get into what ifs. If a scenario doesn't give it to you, it doesn't exist. Someone may be in the house. That's something that you'd have to consider. And in a school setting, if that's something we want you to consider, we'll tell you. Absolutely. I'm not going to try to throw you any curveballs, but I just want you to understand when we talk about scene safety, it's not just about avoidance. You can, if there's no other option, then avoid it. But if you can mitigate it, if you can, she's unconscious and the only threat is the fact that there's a knife or a gun sitting there. So if you go down there, grab the weapon, move it away out of her reach, suddenly scene is safe. All right, that's what I'm getting at. If you walk in and it looks like a crack house or something and you're worried that somebody may be hiding in the closet, then absolutely, that's a whole other thing. All right, so I'm not trying to say that okay, just walk down there. But if that's your threat, if that's what you see, then you can fix that. So let's see, someone may be hiding in the house. Depends, I guess, on the condition of the patient. If she's unconscious, it may not be unsafe. No, if she's unconscious, and even if they are conscious, there's scenarios in the registry where it says you go in to treat a patient that's complaining of chest pain, and you walk in and you see that he's got his revolver sitting on the nightstand next to him. Is that unsafe? Can you approach? The technical answer is yes, you can. However, you need to, talk to your patient and be like, hey, sir, we'd love to give you some help and everything. Do you mind if we move your weapon to the other side of the room? And if he says yes, then cool, move it. Now you're seeing it safe. If he says no, well, that's kind of threatening if he doesn't want to be left apart from his weapon. And then you would say, okay, well, can't come any closer. Pay attention to your details and your surroundings. But that's pretty much, just keep that in mind. Not everything is scene safe, yes or no. It's not black and white. Some things you can mitigate, some things you can't. If you can't mitigate it, like say a hazmat scene, right? Unless you're the hazmat crew and you're going in a level A suit, we don't just run in when the green cloud starts floating around. So some things you can't mitigate, but others you can. All right, some other things to consider for your scene safety. It's not everything is about a weapon and violent people. We have to consider the difficult terrain. So you may have to get a technical rescue team if you're not part of a department that already has that training and equipment. Traffic safety, that's a fantastic thing to call the cops for. Some fire departments in the north, they have what they call fire police. Basically, that's just the reality of it is that's a lot of your retired firefighters who know the work, they know the scenes, they've got all kinds of experience, but they're at a stage where they can't lift patients anymore and that kind of thing. So they'll get out and direct traffic. They're not really police. They just kind of fill that role so that the city cops don't have to stop what they're doing to go direct traffic. All right, so if appropriate, help bystanders from becoming patients, right? If you, for example, roll up on a bus accident, and you got a bunch of people standing around and it's dark, there's a risk that people that are watching this, because everybody wants to see the train wreck, if you move it and there's someone else and you that's true. Can't argue that one. But everybody wants to see the train wreck. So you're going to have people rubbernecking on the street. Somebody may be texting the whole way over the hill and not even know there's a wreck. So if you see people standing around, move them away. Get them to a safe area. Hazards can range from anything from extreme weather conditions to threats of physical violence. You have to be prepared for all that. And an emergency scene is a dynamically changing environment. I may let you get 3/4 of the way through your assessment and then tell you something in passing that has to bring you all the way back to your scene safety. Sometimes that happens. Oh, the new thing recording. What do you mean, Crystal? I don't understand that one. Oh yeah, you'll get people that are sitting there recording the accident. Yeah. All right, so let's talk about your mechanism of injury and your nature of illness. One is for trauma, one is for medical, obviously. Anytime we're dealing with trauma, when we want to assess our mechanism of injury, that is basically just looking at what was it that hurt the person. And, based on looking at this, does it look like it did a little damage or a lot of damage? For example, you show up to a car wreck and you see airbag deployment. The person is wearing a seatbelt and their bumper is just caved in a little bit. Do you consider that just on that? Do you consider that to be a significant mechanism of injury or a minor mechanism of injury?
If the bumper just a little bit pushed in, that's like a minor mechanism injury, unless they complain of neck or leg pain.
Right. But again, like I said, try not to. We could go further into it, but just with what I told you, it is. I agree with you. I would say it's minor. Not that bad. Airbags deploy with a love tap. Sometimes it just depends on how your car gets hit. But now let's flip that. Let's say that you show up to a car wreck. There's a tree in the engine compartment. There's no windshield over the driver's seat. There's no airbag deployment. The seatbelt obviously wasn't used. Your patient is 10 yards in front of the car, and the top half of the steering wheel is bent toward the dash. Is that a significant mechanism of injury or a minor mechanism of injury?
That's a
Right.
significant mechanism.
That's your. If I walked up and that was the first thing I saw, my hopes aren't very high for saving the life of the person in the vehicle. I'm expecting to find body parts. So that's what you're doing, right? You're still assessing your scene. You haven't gotten to your patient yet. So your mechanism of injury is as you look around, how bad does it look like your patient's going to be when you finally get to your patient? All right. And so those are the things you want to consider: the type of force, the amount of force, how long was it applied, and where do you think it was applied? So something like a car wreck happens pretty quick, right? You smack whatever it is real quick. Mechanism of injury doesn't really get prolonged. But let's say we're talking about a structure fire. Somebody was pulled out of the building and they've got significant burns to their body. That could have been, the mechanism would have been the fire, the burns. And they could have been applied for a long time. Same thing with chemicals, right? Somebody spills chemical on themselves and it burns them. That's a mechanism of injury. And depending on how long it took them to get it off of them, it could be a long duration. Some things aren't so bad if you get them off of you quick. Some things, the longer they're on you, the worse it is. Certain parts of the body are more easily injured than others. So like your eyes, for example, we have some natural bone formations that protect our eyes. If you were to take your hand and press on your eye, flat palm, you're going to catch like where your eyebrow is, you're going to catch that bone, your cheekbone, that kind of thing. Those are there to protect your eye. But if you go at it with a finger, you're going to get your eye. So even though we have some natural protections to our body, they're not that great. They're designed for typical things. Like if you're me, you stub your toe on everything, fall down the stairs, fall up the stairs. That's happened before. But our bodies aren't designed to protect us from a car wreck. We haven't evolved to that. Hopefully it's not something that we ever will, because that doesn't happen to everybody. But even the things that we are designed to protect ourselves against, like your rib cage only protects your thoracic cavity. Your diaphragm and everything below it is only protected by your abdominal wall, which is nothing but a muscle. You can poke that. That's not going to protect you very well. So, keep that in mind. Certain areas get worse. That's why seatbelt injuries can be bad. However, you know what? I'm going to save that soapbox for when we get to trauma. I'm a very big advocate for seatbelts. I wasn't always, but I know their main purpose, I'll just say that, is it's not to keep you from going through your windshield. Anyway, so with blunt trauma, the force of the injury occurs over a broad area, and that could be the size of a fist. That could be the size of your steering wheel. that kind of thing. Blunt trauma, the problem with that is it doesn't always break the skin. So you could break bones, you could puncture organs, that kind of thing with blunt trauma, and you'll never see a drop of blood from it. So keep that in mind. When you're dealing with blunt trauma, we are worried about the organs and the blood vessels that are underneath the skin, even though the skin may be intact. With penetrating trauma, that is something it could be anything from getting hit with a piece of rebar and it going through. It could be a knife wound, a gunshot wound, any of that stuff. These are open wounds. They may or may not go all the way through. It depends on what it is. And you still have to worry about the organs underneath. But when you're dealing with penetrating trauma, with a couple of exceptions, usually you can pretty much say that only you look at your mechanism, say somebody got stabbed with a 3-inch blade. The only organs that are going to be damaged are the organs that 3-inch blade could reach. But if somebody got shot with, I don't know, 50 cal Desert Eagle or something like that, first of all, you have the bullet wound, the entrance wound. You're definitely going to have an exit wound for something like that. And the way that bullets travel and the way they spin, the cavitation that bullet would create would damage all the organs around it as well. So, yeah. It was the last weapon I shot. It was the first one to come to mind. But anyway, but both require you to search for clues. You're not always going to see all the injuries, especially when you're dealing with internal organs, unless you got a really bad day and a really bad patient in front of you. So to quickly determine the NOI, let's talk about that for a second. There we go. Now we're talking about medical calls. All right. It's kind of hard to do that. You can't look at somebody and say, yep, you look like you're having a heart attack, other than a couple of signs. So to get your NOI, talk with patients, talk with the family, bystanders, anybody, if somebody has seizures, you can ask them, do they normally have seizures? Is this new? That kind of thing. Use your senses to check the scene for clues as to the possible problem. Sometimes the answer to what's wrong with your patient is not on your patient, it's somewhere else in the room. Or it could be the time of year, right? If you've got a patient that's been throwing up sick, you go in there, you find them either unconscious or in an altered level of consciousness. And he has a gas-fed heater, and it's the middle of January in New York. That kind of thing, right? So you can't see carbon monoxide poisoning, but you can look around and you can see what would be possibly giving him that. So that would be your nature of illness. Be aware of scenes with multiple patients who are exhibiting similar signs or symptoms. A lot of times that tells you that what you're dealing with is environmental, and you especially probably don't want to be in the same room with them if that's the case, because you're breathing in whatever it is, or you're at risk of whatever it is that got more than one person. Those kind of things, that's not something you can mitigate. So that's an example of backing out, calling in the fire department, putting on some SCBA where you're not breathing that room air, and getting your patient out to better environment for themselves. The importance of your mechanism and your nature. Consider the MOI or NOI early. If the earlier you can get that, the better idea you can get of what to do with your patient. Again, your assessment, you must know your assessment. However, your assessment does not treat your patient. All right, your assessment is used to determine the treatment for your patient. So the sooner you figure out your MOI and NOI, the sooner you can start to think in your head, what do I need to do for this guy? For example, we have little acronyms that we use in EMS, especially at paramedics. But yeah, I'm going to teach you all this one because only one of these you can't really do on your own. If we have a cardiac patient, any kind of cardiac issue, their chest hurts, that kind of thing, we have an acronym called MONA or FONA, either the M or the F. And it just depends on what medication the paramedic has. But that is either morphine or fentanyl for pain relief, oxygen, nitro, and aspirin. All right. Now, you as EMTs, you can go ahead and toss out the morphine and fentanyl. There's no way that you'll ever do that as an EMT. But oxygen you can give, nitro you can assist with, same with the aspirin. And depending on where you're at, you can actually give the patient aspirin. So you walk in, they say they're having chest pain, you're immediately going to go, cool, I can give 3 things for this, right? But You don't want to just give it to them. Oxygen, yeah, sure, you can just give that to them. But nitros, there's a lot of things that can say that would say don't give a nitro to somebody, like their blood pressure's too low or they took Viagra, that kind of thing. Same thing with aspirin. We give aspirin to people and there's really no side effect to it, but if they just took an aspirin, some systems are saying don't give it to them because they might overdose or it might cause other problems. Some systems are saying screw it, give it anyway, it'll be fine. The problems you get are much less severe than death. But that's where your assessment comes in, and the sooner you can figure out what you're looking at, the sooner you can start to figure out what kind of treatment you want to give, and then you model your assessment to that treatment to make sure, okay, well, this is what I want to do. So let me make sure by using my assessment that I can do this, because if I can't, then I need to figure something else out. Standard precautions. These are the things that you do to protect yourself every single time. For a long time, it was just gloves. Now, in most of the training, we see they're doing gloves and goggles. These days, what's something new that they're adding into standard protocol or standard precautions now within the last, I don't know, 6 months? Right, masks. Because now we've got something going on that's droplet based. It's not like they put out there the other day that they thought it was aerosolized, but it hadn't. That was a mistake. But it's droplet based. That's what COVID can be spread by droplets when you sneeze, droplets when you talk, all that kind of thing. So masks have become standard precautions because it's really hard to treat your patient if you're not going to get within 6 feet of them. Mask and hazard suits. Yeah, so your hazard suits and your aprons are PPE, but they're not necessarily standard precautions because you don't use them every single time. So standard, think of that as all the time, right? So you're always going to wear gloves. You're always going to, at this point, we're always going to wear a mask. That would, you could consider that to be standard precautions. Now they're saying it can last in a person up to 6 months after positive. That's new to me. Wow. Yeah, be careful if that's the case. I haven't heard that, but that doesn't mean jack. I haven't heard. There's a lot of stuff I don't know about this virus. Let's see. Standard precautions have been recommended for use in dealing with objects, blood, body fluids, other potential exposure risks of communicable disease, hence the masks, that kind of thing. Your objects for PPE, there's not a lot that you will wear as EMS. The first thing that comes to mind, because I know a lot of systems are going toward this, is plates, wearing a vest, because some EMTs go into bad neighborhoods. We go in, they're actually trying to get it to where we go in with the strike teams in active shooter situations to take care of patients faster. So depending on where you work and depending on how your AHJ, your authority having jurisdiction, how they determine they want to do it, you might be going in on strike teams with the police. That might be what you want to do. So that would become one of your PPE items. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. So in other words, don't get to your patient, shake his hand, get blood all over you, and then go, hey, maybe I should put gloves on, right? They want you to at least have your gloves on once you get to the scene. So before you open your door, put your gloves on. And then they need to be off of you before you go back to your truck because you don't want to cross-contaminate your own rig with somebody else's stuff. Every patient gets their own set of gloves. So if you have 3 patients you're working on, you work on patient 1, you have a set of gloves on. When you go to patient 2, those gloves come off, another set comes on. You go to patient 3, swap your gloves, that kind of thing. Because you're not just protecting yourself, you're protecting them from each other. Patient 1 might have hepatitis, patient 2 does not. If you don't change your gloves, patient 2 might have hepatitis, and that's your fault. So we don't want that to happen. Determine your number of patients. If you look at your assessment, these are the items that we're going over. Let's see, do you recommend double glove or no? I see some double glove at scenes and ERs. Me personally, one set's enough. If my gloves get compromised, I'm just going to pull them off and put another set on. Double gloving, I guess if you're worried about abrasions ripping your gloves halfway through, you can double glove. The gloves themselves aren't going to really cause any issues with each other, but it's kind of overkill if all you're doing is checking the blood pressure and that kind of thing. All right, so anyway, during the size up, it's important to accurately identify the total number of patients, and that's everybody from the nosebleed to the broken foot. It doesn't mean you're going to work on every one of them, but you want to know how many you got because you want to know how many ambulances you need. All right. This is critical in determining your need for additional resources. When there are multiple patients, you should use the incident command system, which has anybody in here not taken ICS 100 or 200 or 700? And it's okay if you haven't. Those of you that are already EMTs, or not EMTs, those already EMRs or police, fire, that kind of thing, you've probably already taken it. Those of you that are coming in off the street and just getting into this, if you go to work for an agency like Pafford or AAA or something like that, you're going to have to take it. But it's free, it's fast, the answers are on Google, which sucks because nobody actually takes the training. But that is basically showing you how, yeah, it's for free on FEMA. You don't have to do it for this class, but you'll probably wind up having to do it for the agency you go to work for. But that explains incident command structure, where if you show up on a scene and it's just you, congratulations, you're the incident commander. If you show up on a scene and it's because, Hurricane Sally came through and wiped out 2 states or something like that, or back to Katrina, the incident command system is basically how a standardized way of everybody knowing who's in charge, who's over what, how the system is laid out, and it makes it to where some of that chaos goes away. But if you have multiple patients, you're going to need multiple trucks. Now, who's in charge? That kind of thing. So ICS is very useful in that. You don't have to be an ICS master in this class, so don't worry about it. But yes, take some time. Maybe not when you're needing to study this stuff, but take some time and learn that. It's good. And if you go to work for an agency, you're going to need to know it. Triage is the process of sorting patients based on the severity of each patient's condition. So going back to the bus wreck or the train wreck, if you've got 20 patients, and of those 20, 15 of them have, cuts and scrapes, and that's it. You can make them all go sit in the shade of a tree somewhere while you work on the 5 critical patients. That's what triage is you're determining everybody's severity before you do any patient care. And if you have enough people, the user determine who is the main god on the scene. I guess so. That's one way of looking at it. Well, anyway. All right, this slide is for triage, so let's get that one. Consider your additional resources. At this point, you should have an idea of what you need, right? You've already done your BSI scene safety, so if there's a gas cloud, you know not to go into it. We've already looked to see how many patients we have, because we've looked at the mechanism of injury and all these things that would determine if we needed any outside help. So now let's consider, based on what we know, do we need any additional resources? And that could be more ambulances. Specialized resources could be something like hazmat teams, like you see on the picture, the fire department, cops, any of those. All right, specialized resources could be, like we said, advanced life support, especially if you're on a basic truck. Air medical support. So down here in this area where I'm at the moment, you guys have Rescue 7 and a couple other helicopters. If you think you need one, radio them early. It's okay, so that they can go ahead and be getting en route. You can always cancel them if you don't need them, but sometimes it takes them a little bit to get there. So don't wait until late in the call to make that decision. Fire departments can be a catch-all. If you don't know, call the fire department. We may not be the best at handling everything, but we're trained to do a little bit with a lot. So fire departments, at least in this area, we have hazmat, we have tech rescue, We handle extrications. We have the tools to cut cars open, like vegetable cans, car fires, wilderness fires, search and rescue, all that good stuff. And then some of the departments down here, like carrier, they are real big on water rescue because they're right there next to the locks and everything on the Pearl River. Law enforcement can keep your scene safe when somebody is being violent or just a threat in general. If it's a crime scene, they need to be there. If it's a violent scene, they need to be there, and they should be the first ones in. So, consider like an active shooter. You don't want to run in and try to do patient care while the guy's still shooting people. So, because then you're going to wind up being shot too. Law enforcement are there to control the scene. They are there. You're worried about your own safety, but they are very good at maintaining order. So if that's your issue, get them out there. To determine if you need additional resources, ask yourself, does the scene pose a threat? How many patients are there? If there's more than one patient, probably going to need more than one provider. All right. So all of that is just to get you to your patient. All right. Again, if you look at it, sounds like a lot, but we're basically going over what you need to worry about in each of those lines. Your assessment has them all labeled out. Like I said, I need you to memorize them, not tonight, not for this next coming test, but by boot camp. I would really love to see nobody relying on their checklist. You can have it with you, but I would like to see everybody, for the most part, being pretty much, we've got this memorized. And then we can go into scenarios much faster. And you guys, the faster we get you to where you're not having to sit there and read off the sheet for everything you do, the faster we can start really giving you some fun scenarios, some fun here. Let's throw this curveball at you and see what you do, and that kind of thing, and make you guys better. That way you come out of school ready to go. Anyway, all right. Primary assessment. This is where you begin to actually talk to your patient or treat your patient, that kind of thing. You're really worried about your mental status and your life threats. So the goal is to identify and initiate treatment of immediate or potential life threats. And this is physically examine the patient to assess their LOC, which is level of consciousness, and their ABCs, which is their airway, breathing, and circulation. All right, so you want to know if they're physiologically able to live, because you need those three things. And then you want to make sure that they're not suffering from some kind of head trauma, right? Because depending on if they did hit their head, let's say they have a TBI, which we have a chapter for that at the end, they might be fine as far as their ABCs are concerned at the moment. But if they're showing signs of traumatic brain injury, the altered level of consciousness is the first thing you see. If they're going hypoxic, their level of consciousness and their mental acuity is the first thing you're going to see. Their anxiety is going to rise. So before you look for blue lips, which is what everybody likes to say is a sign of hypoxia, and that's not wrong, that's just a really late sign. There's a lot of things you'll see before their skin turns blue that you can, fix that problem before it gets that bad. Their LOC is one of those things. The new CPR does kind of close. So CPR currently does CAB, circulation first. And no, we don't change the order. And the reason being, and I'll go ahead and say this, if you all look at your assessments, the very first thing before you do your ABCs is check level of consciousness. So you're going to get to your patient and you're going to, hey, are you okay? Just like you did in CPR, right? If they're unconscious, well, are they dead or alive at that point? So you check a pulse. If they have a pulse, then you're not going down the CPR route. You're going down the primary assessment route. And if they don't have a pulse, make sure I'm not just doubling up what I'm saying here. If they don't have a pulse, then, okay, nothing else matters. We need to go down the CPR route. But you're going to make that determination before you actually get to your ABCs. Good question, because that tricks a lot of people. And we'll go over that. So like I said, when we start doing scenarios, I'm not going to tell you right off the bat you have CPR patient. Okay, I knew it was different. Yeah, so it is, and it is. When you get to your primary, though, you're going to make the determination of, does this patient need CPR? It's the absolute very first thing you do. If they don't need CPR, then you go ABC and you continue on with your assessment. If they do need CPR, they need immediate intervention. And that's when you go down your CPR route, which is a little bit out of order. But even then, it's still your ABCs are next. You're just moving C to the beginning. You're not pulling anything out of your primary and doing later. You're not plugging anything into the primary that doesn't belong there. So even with the changes, it's still kind of the same. Anyway, all right, moving on. So your general impression, this is what does your patient look like to you? And this is subjective because this is your opinion of your patient. If somebody says, ow, my foot hurts, and that's exactly how they said it to you. It hurts so bad. Oh my God, it's the worst pain I've ever felt. Did you see the game yesterday? That kind of thing. Yeah, what's your pain from a 1 to 10? Oh, it's a 10. This is absolutely the worst pain I've ever felt. I need you to bring me to the doctor. They're like the farthest one out because they have my medical records, that kind of thing. So does your general impression match with what your patient is saying? At that point, your patient's basically telling you that they're dying, but they sound like they could care less. No, not really. So short of a head injury, that's an issue, right? Or not really an issue, but that's something for you to keep in mind. Whereas the other way around, and this is what you would actually see if it was a true emergency, somebody's clutching their chest, they're bent over in a tripod position, they can't breathe, and they're like, oh my God, it hurts. But they tell you, I'm fine, I don't need help, I'm good, that kind of thing. Well, no, and that's kind of what you were seeing in that first discussion question you had back in module 1. You had a guy that was obviously about to die in front of you, but he didn't want the help. So he's trying to tell you he's okay and he doesn't want you to treat him and that kind of thing. So your general impression at that point is saying, no, dude, you need it, even though he's saying something different. All right. So your general impression, you're basically going to assess what's in front of you. And we give this general impression when we radio the hospital. If you've ever heard somebody say, all right, I've got a 72-year-old male complaining of blah, 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 blah. That's your you're basically giving them your general impression of what you saw, but you're also telling them, that's how you start off telling them what you're bringing into them. So note their age, sex, and race. Those 3 things matter. Demographically, we typically don't see heart attacks in a 5-year-old. Sometimes it happens, but it's like 0.001% of the population. Their sex matters. Women register pain differently than men. People talk about pain thresholds being higher for one or the other. It's not necessarily higher. It just differs differently. So an example would be if a male tells you that he has, or if a male is having a heart attack, he will tell you that he has chest pain, radiating down the left arm, all your classic signs, right? If a female tells you she's having, or I'm sorry, not tells you, but if a female is having a heart attack, she's more likely to tell you that she's got indigestion, that her stomach hurts, and things like that. They feel the pain in a different area in a different way. That matters. You may not know that, so it's important to tell that to the hospital because the doctor may be like, "Aha, that's a deferred pain," or something like that. That's demographically different, and you're not expected to know that at the EMT level. You go into 1 semester of a class. That guy went to 16 years of school. He should know that. And then their race. It also matters. Sickle cell anemia is much more prevalent in African Americans than it is in Caucasian people. Doesn't mean that white people don't get it, but it's just a lot more common. So that also plays into it. Even in your general impression, if somebody's having the signs of sickle cell and you're talking to an African American, it really raises the chance that what you're dealing with is sickle cell. All right. Note their level of distress. Again, if they're losing oxygen in their perfusion, if their blood's not carrying enough oxygen, the very first thing that's going to change is their level of distress, right? The minute you start to not be able to catch your breath, your anxiety climbs. Your overall appearance, so you just take a step back and look at your patient. That's where the sweating comes in. If you see somebody that's tripoding, where they have a hard time breathing and they're diaphoretic, you can't really fake signs of things. You can kind of fudge symptoms, right? I can tell you that my stomach hurts, but it really doesn't. But if I'm sitting there and I'm profusely sweating and I've got, pinpoint pupils and different things like that, that's not something you can fake. So your general impression can kind of give you an idea of what's really going on. All right, it is 7 o'clock. I'm actually in your time zone now, so I'm telling you the right times. Take a 10-minute break. We'll be back at 7:10, and we'll continue on with the general impression. know it's only 7:08, but I'm gonna go ahead and get us back going. And when people come in, just come on back. Let's see, Rob, did everyone do the what would you do in module 1? So not everybody has done the discussion. I do absolutely want to talk about it because I think it'll be a good discussion. You guys will be surprised at what you could have done, that kind of thing. But and pretty much everybody agreed that they would have just got a refusal, that's what I expect. All right, I know a lot of people would. That's why I make that discussion question, because I wanted to see if anybody caught it and what you would think. Like I said, those questions aren't necessarily right and wrong. They're to help you put into the real world, put your perspective, get out of the class setting and into what is it going to be like when you go to those calls. So yeah, we'll discuss that. I'm not quite sure how I want to do it. We may do it here in the class. We may do it on the Facebook group. You know, I don't know. We'll figure it out. But yeah, I definitely want to, at least this one, just based on the answers and everything, I would love to talk about it and just kind of get y'all to think in a different way, I guess. Anyway, all right. So moving back on, we're going to finish up with general impression. Then we're going to talk about level of consciousness, and after that, we're going to really start to go faster because I'm not going to try to make you guys masters of your ABCs tonight. We're going to have chapters completely devoted to all that. So we're just going to hit the high points after we get through this part. Anyway, still on your general impression, as you make your approach, take note of a couple things, right? So note the patient's position. If they're tripoding, breathing heavy and everything, that should tell you immediately without doing any other assessment that they're having trouble breathing. So go ahead and be getting into your mind, what am I going to do for trouble breathing? Avoid standing over the patient. Nobody likes that. Not even when they're feeling fine do people like that. So try not to do it when they're having that kind of a bad day that they call 911. Address your patient by name if they want you to. And you just flat out ask them, say, hey, my name's Rob. I'm going to be your EMT today. What's your name? And then they'll tell you, and you right there, just be like, okay, would you like me to call you? Would you like me to use your first name or sir and ma'am, that kind of thing? They'll tell you if they don't want you to say, and you can even just ask them like, what do other people call you? What would you, that kind of thing. It's up to you. Introduce yourself to the patient and ask about the chief complaint. So here's the thing. Like I said, we want you to learn your assessments line by line. But if you introduce yourself to the patient and you extend your hand to shake hands or something like that, and they say, hey, I'm Jim, and they shake your hand, well, you got a response out of them. They're alert. They had to have a patent airway and breathe to build the words to tell you their name. They've got good coordination. They shook your hand. You can tell by how they shook your hand whether or not they're having weakness on that side, things like that. So just in doing that, you've knocked out most of your primary assessment right there on the spot. When you go to do your ride-alongs, you're going to see that that's kind of how that's how we do it in the real world. That is one difference in the class versus what you're going to do outside the class. But even when we do that, we're still in our heads checking off that assessment. We're just not doing it out loud, right? So keep that in mind. The patient's response can give you insight into his level of consciousness, his air patency, respiratory status, and overall circulatory status. If they have any life-threatening problems, treat them right then and there. There is no noting and coming back to it if it's a life threat. All right. So if they're not breathing, we need to breathe for them. If they don't have a pulse, we need to be doing compressions and giving them a pulse. That's basically all CPR is. If you think about it, you have your ABCs that you need to live. And if they don't have those, you're going to give it to them. And that's what you're doing in CPR. You're giving them a pulse by compressing on the chest. You're giving them breaths with the BVM or the pocket mask or whatever it is that you've got. But at the end of your general impression, when you've looked at your patient, kind of sized them up a little bit, you're going to basically determine whether your patient is stable, unstable, or if he's somewhere in the middle. All right. And like I said, when we're giving you scenarios, they're always going to be unstable patients because I want to see you get through your assessment, how you deal with some pretty bad stuff. I'm not going to waste your time or mine having you try to assess a stub toe. All right. So once you get your general impression, you're going to assess your level of consciousness, and we use AVPU at first. When you're in your primary assessment, you really don't have to get a GCS score. That takes a little bit of time. It takes a lot of practice. So when you're just real quick trying to get through your primary to make sure your patient's not going to die on you in the next 10 seconds, AVPU is fine. That is AVPU, A for alert, V for verbal, P for pain, and U for unconscious. So if you walk up, think about when you did CPR. You walk up, hey, are you okay? You know, because he's laying on the ground. Well, if he answers you when you shout at him, he is responding to verbal stimulus. So he would be V on the AVPU. If he doesn't, and you have to pinch him on the shoulder, do a sternum rub, you know, flick the bottom of the foot if it's an infant or whatever it is that we teach you to do based on the patient in front of you. If he responds to that, then he's responsive to painful stimuli. And that's a good thing. All right. If they're that bad off, they're unconscious, but they're still responding to pain, it could be worse. All right. But if you do both of those things and they don't respond to you at all, there's nothing happening, then they're unresponsive. And immediately your next thing is go check a pulse. All right, because that's going to be that's where you're at a fork in the road. Am I dealing with cardiac arrest, or am I going to continue on with my assessment as I'm looking at it on this piece of paper? If they don't have a pulse, you're doing CPR. If they do have a pulse, then you just continue trucking along like normal. All right. All right, so here's your categories. Again, we use AVPU is the easiest way to do it. Assessment of an unconscious patient focuses on airway, breathing, and circulation if they have it. If they don't, then you're going to be going down the CPR route, which just moves circulation to the beginning. Get caught up to my slide here. All right. Nope, that's actually not the slide I want to be on. Let me see. There's AVPU. All right, so now I'm getting caught up. So this is the way to check for painful stimulus. You can pinch the ear, press down above the bone of the eye. We don't really do any of these. The big ones that we do is we pinch the shoulders. If you've ever done that to somebody, you know, or had it done to you, you know it hurts, right? That's something that like schoolyard bullies used to do to kids. We do it to try to inflict some non-injuring pain. If they're going to respond at all, they're going to respond to that. Same thing with a sternum rub. That's where you take your knuckles and you kind of rub along the sternum in the middle of the chest. It doesn't really cause damage, but oof, it hurts. Babies, we don't want to do that to. Babies have a reflex that will tap the bottom of their foot and they'll kind of kick, or not tap, I'm sorry, you take your finger and you just kind of rake it along the bottom of their foot and they'll kick their foot away. That's a reflex. That's not a conscious decision. So yeah, if they don't like it. But if the baby's unconscious, I mean, that's what you're doing. You're checking to see if they even at least still have reflexes. You can also kind of flick or thump the eyes. That just, I mean, you can, but I don't know if I would do that. Is that what y'all do out there? Not trying to call anybody out. I'm just curious. Is that a regional thing, or? That makes me hurt just thinking about it. Somebody thumping me in the eye. You're checking for two different things. If I thought somebody was faking, I would tell my partner, hey, flick him in the eye, see if he flinches. So, but I wouldn't actually do it. I feel like that would be assault. Anyway, all right. So it's not, now we're still going on with our level of consciousness here. It's not just enough to know whether somebody is alert. We want to know if they know, if they're, you know, the lights are on, but is somebody home, right? So we do an orientation. You've ever heard A&O times 3? This one does have 4. There's an event there. Probably won't be tested on the 4th one. I've never seen that. Besides, I don't know what event you would use, but these questions have to be questions that anybody can answer and that you would know as well. So, person. A lot of people always default to saying, "What's your name?" But unless you're looking at the guy's driver's license or something, we really don't necessarily know his name. He might tell you his name's John and he's wrong. That could be his brother's name or something. So I'll ask him, who's the president? Um, that's an easy one, right? Who's the president? Whether or not you voted for him, the president is the president. Place, ask him where he's at. Time, make it broad. Say like, do you know what month it is? I forget what day it is all the time. So that would I feel a little shorted if somebody asked me that question. Some of the medics do it that after rubbing pinch before the Narcan. Yeah, okay, so yeah, that's what I was saying. Like you're talking about a certain type of patient. All right, so when we do this, we're actually checking their long-term memory, intermediate-term memory, and short-term. If the patient knows all these facts, the patient is said to be alert and oriented. ANO times 3 is your standard, but by this curriculum, there is that fourth one. Any deviation from alert and oriented to a person, place, time, and event, according to this one, or from a patient's normal baseline is considered an altered mental status. So an example of this we had right there at the gate for at my base. Guy had a seizure, fell out, hit the ground. But when we got there, he was lucid, he was up talking to people, and he looked fine. I mean, he wasn't slurring his speech, he wasn't falling asleep, he was walking around talking, and he was holding conversations with his coworkers that they thought he was fine. So, we're like, all right, well, do you have a history of seizures? He said yes. So like, okay, so this isn't some new emergency. So we're gonna go get our handy dandy refusal forms, and we're gonna take our butts back to the station. We go get the form, and when we get back, we just to verify his A&O, because we always want to do that to make sure that he can sign. I told him, I was like, all right, well, I'm gonna ask you some dumb questions. Just bear with me, and we'll get this form signed, and you'll be on your way. Asked him who the president was. He got it. Asked him where he was. He did not get that one. He thought he was standing outside of a hotel, which I'm like, okay, the front gate kind of looks like a hotel, so I'm gonna. That's a yellow flag for me. Do you know what year it is? He thought the year was 1967. And then at that point, I realized he really did think he was standing outside of a hotel. He was stuck in a like a memory loop or something. So whatever happened to him, it knocked him back 30 years. He eventually started to come out of that, but we couldn't let him sign the refusal, so we had to take him to the hospital. Okay, so an event, do you know what's happening, like why I'm here? So that would have been it. So with him, I would have asked him, do you know why we're here? Oh, I had a seizure. That would be oriented to the event. Sometimes your patient may not know that. That doesn't necessarily mean that they are not oriented, because what if they're not the one that called 911? What if it depends on what it is. Whatever it was, they may not have known 911 was called. That one can kind of be a gray area, but that's still a very good example of what an event is. I just don't know if I would rule somebody not oriented based on it, because it just depends on the situation. All right, so identify your life threats. Some things can cause sudden death, and this is what we want to watch out for when we're in our primary assessment. So airway obstructions, like they're choking on a piece of steak, respiratory failure, respiratory arrest, shock, severe bleeding, primary cardiac arrest. Any of these things, got to fix it. All right, can't go on to the rest of your assessment if you see these and don't fix them. In fact, if you see these and don't fix them, we'll just go ahead and stop you and fail you because you let your patient die. In most cases, identifying or correcting life-threatening issues begins with the airway, followed by breathing and circulation. That's why we call it the ABCs. This is assuming that they're not in cardiac arrest. And that's why it says on the site, in some cases, it may be appropriate to address life threats to circulation first. So if they, you like I said, you show up, they're unconscious, you check a pulse, they don't have a pulse, give them a pulse. All right, now you're going down CPR. So assessing your airway, once you've gotten to this point, the main thing that we need here is to know that they can ventilate themselves. It's not about their oxygenation or anything like that. Don't think about getting an O2 sat. In fact, if you do an O2 sat in your primary, I'm going to slap you. Not really, but don't do it. Everybody does it. In A, we are only worried about, is the road system still functioning? Can I get air from outside the body into the lungs? If the tongue is in the way, then I don't have a good airway. I need to move the tongue. We have devices for that. If the epiglottis is in the way, we need a paramedic. If they're choking on a piece of steak, we can try to do the Heimlich maneuver. If they are still conscious, if they're not, then we move into CPR, that kind of thing. But that's what you're worried about here. All right. So we want to make sure that we have an open airway, and we can do that in a couple different ways. If anybody heard head tilt, chin lift, or jaw thrust? If you've ever taken CPR, I know you've heard head tilt, chin, because that's what we teach. But if you as EMTs, you guys aren't trained to the same level as the guy that works at Walmart or the high school student, the 15-year-old babysitter, right? You guys are professionals. You're going to be professionals. You're going to be badasses at this, and I need you guys to know more. So if it's a medical call and there's no risk to the neck as far as trauma goes, which one are we going to use? Head tilt or jaw thrust? The head tilt. All right. If it's a car wreck, your patient's unconscious in the car, and it, pretty significant MOI, or even if it doesn't look like a significant MOI, if he's unconscious in a car wreck, we can't rule out trauma. Which are we going to use now? Head tilt or jaw thrust? Good. So the jaw thrust is basically you're just lifting the jaw forward, or if your patient's laying down, you're lifting the jaw up. But you're basically pulling the tongue away from the back of the throat without moving the neck. The head stays in a neutral position as opposed to the head tilt chin lift. But just moving the jaw, even doing a jaw thrust or a head tilt chin lift is not enough. We have to put in an airway adjunct, right? So that's either our OPA or an NPA. Once that's in, the airway is considered patent, and then we can move on from there. All right, if your patient is responsive, if they're talking to you, they have a good airway. If it's a baby crying, they have a good airway. If they're coughing because they have a partial obstruction, let them cough. All right, that's all right. A lot of times they will get it up on their own. If they don't, if it winds up being that it falls further in and they get a full airway obstruction, then yeah, we're going to do the Heimlich and stuff. But Heimlich maneuver on a partial airway does nothing. So don't I'm going to say don't waste your time, but really and truly that's what it means. Don't waste your time trying to do abdominal thrusts if they have a partial airway, because all the air that you force through them is just going to go right around the object. It's not going to actually move it. It has to be a complete blockage for the Heimlich to work. So listen to how the patient speaks. Listen to how air moves. If you're hearing wheezing, if you're hearing rales, bronchi, stuff like that. And when we get to the airway chapter, I'm gonna play what some of those things sound like so that you know what the breathing sounds like. Those are important things. And when you start actually doing your assessments and everything, I want you to listen to breath sounds on every single patient. All right, that's a vital sign. You don't have to do it in this point, but in your assessment, listen to them. Because if you listen to 1,000 patients with normal breath sounds, when you get that one that doesn't have it and they have something wrong, it's going to stand out plain as day. You're like, holy crap, that's not right. Even if you don't know what it is. All right, unresponsive patients, immediately assess the airway unless they don't have a pulse, in which case you're going to compressions first. But if they do have a pulse, immediately assess the airway, do your jaw thrust or your head tilt, and then use your adjunct. If they're conscious at all, you're not going to be able to get an OPA in. They're going to gag on it. But if they're so far out that they don't even have their reflexes anymore, the OPA is the better of the two. It just depends on whether or not they can take it. All right, signs of obstruction in an unconscious patient: obvious trauma, blood, obstruction, stake, quarters, Jolly Ranchers. I can't tell you how many times I choked on those. Extremely shallow or absent breathing. All right, so moving on to breathing itself. We've checked A. We now know that we have a clear way. Now we got to make sure that the air that's going in is actually getting past the lungs and into their body. So we're going to make sure that the patient's airway is open. Make sure that, which you've already done, and we're going to make sure that the breathing is present and adequate. So ask yourself, first of all, are they breathing? All right, do I see them taking a breath at all? If I do see them taking a breath, is the patient breathing adequately? So we talked about in lifespan and development, your average adult, we'll deal with adults for the bulk of this class, breathes 12 to 20 times a minute. But we also learned about minute volume and stuff like that. So if I told you that your patient was breathing 15 times a minute, based on that, would you tell me that their breathing is good? If I told you nothing else, don't make any assumptions, but if all I said was they're breathing 15 times a minute, would you consider, okay, good, yeah, that's adequate breathing based on what I gave you. Now, if I told you that they were breathing 15 times a minute, but very, very shallow, right? Okay, so just because they're in the range doesn't mean that they're normal. If that's all you get is a range, as far as like the questions on the test or something like that, don't plug in information that's not given to you. So if all you get is a range, that's all they're wanting you to look at. And then you're just worried about, well, is it between 12 and 20? Yes, okay. If somebody's breathing 24 times a minute, that may or 24 is not that far out of range. I'd still consider that pretty good. If somebody's breathing 40 times a minute, that's a problem. Somebody's breathing 6 times a minute, 4 times a minute, that's a problem. Okay, so just keep that in mind. So are they breathing? And then are they breathing adequately? And also look at your patient, are they hypoxic? Because they might have 12 to 20 breaths a minute and they're good depth and everything, but for whatever reason, they're blue. Where do you think the problem is in that situation? And I'll tell you this, if they are hypoxic, they won't breathe in range. Their rate's going to start to kick up real fast. But what do you think would be the issue? Or any issue? Give me just an example of somebody who would be breathing normally but not getting oxygen into their bloodstream. Okay, problem could be the exchange. So congestive heart failure would be one, where they've got fluid in the lungs. Carbon monoxide poisoning is a big one because of what that's actually doing to you. Now you're thinking about blood problems at that point. So that's a very good one. Does somebody else think of another blood issue that could cause that problem? COPD, yeah, COPD is a problem with the alveoli. Sickle cell anemia is a big one. All right, that's where your red blood cells that carry your oxygen around, they shrivel up. They can't, and because they shrivel, they can't hold the oxygen. So your body says, I've got plenty of red blood cells. I'm not going to pump any more into the system because we're already at capacity. Problem is those red blood cells can't do what they're supposed to do. So even though you're breathing in and everything's working right, the blood can't pick up the oxygen. So there's no oxygen to transport. So it's things like that. All right. So keep that in mind. The patient's hypoxic. Look at what they're doing. If you see that they're breathing normally, but they're still showing signs of hypoxia, start thinking about the different things that could do that. Asthma is more of a airway problem. Same thing with bronchitis. Those are problems with the actual pathway. All right. Consider providing positive pressure ventilations with an airway adjunct when the respirations exceed 28 a minute, or whether they're fewer than 8. So 12 to 20 is your range by the textbook, but people, like I said, those are it's not a definite 21 and you're too high. It's that's just your guideline. So if somebody's breathing over 28 times a minute, but they look fine, let them breathe over 28 times a minute. If that is a problem, you're going to see that manifest in other ways. If somebody's breathing fewer than 8 times a minute, usually that is an issue. But again, treat your patient, not your numbers. If you see somebody breathing 7 times a minute and they're up talking to you like nothing's going wrong and they look fine, and you don't see any signs of hypoxia, screw it. Let them breathe 7 times a minute. It's working. The goal for oxygenation for most patients is an O2 sat of at least 94, but we stop it at 99. We used to just give everybody 15 liters on their breather and say, have a nice day. But the problem with that is that if we over-oxygenate a patient, with a couple of exceptions we'll get to, like strokes, but if you over-oxygenate your patient, the oxygen, all that excess breaks apart, and it's like wrecking balls going through your body on a atomic level. Those little free radicals of oxygen will start tearing crap up. Your cells are going to get destroyed. Too much of it can start to cause organ failure, system failure, and then you could actually kill your patient from over-oxygenation. So we don't do that anymore. We actually use the cannulas a lot more often than we do the non-breathers now for that reason. So why would a cardiologist tell you to keep less than 94? Depends on what you're dealing with. Some COPD patients, is that what are, I don't want you to, especially if it's you, I don't want you to put anything into the class you don't want to, but if it's a COPD patient, sometimes because of having your carbonic drive or your hypoxic drive, whichever one of those systems your body is using to say, hey, it's time to breathe. Okay. There's two systems in the body. We use the carbonic drive to breathe. When our carbon dioxide levels get high, our body triggers faster breathing. But if you have COPD, your carbon dioxide stays high. So you basically flood the engine. All your receptors that are watching to see how high your carbon dioxide gets, they flood out, they stop working. So your carbonic drive doesn't really work for you anymore. So your backup system is called the hypoxic drive, and that's a different set of receptors that are watching how low the oxygen gets. If the oxygen doesn't fall below a certain point, your body doesn't get triggered to breathe. So if you oxygenate somebody too high, and that's the system they're working on, you actually shut their respiratory drive out. They never get the urge to breathe. COPD patients, long-term chronic COPD patients get that. Emphysema patients, that kind of thing. So if your cardiologist is telling you that, or your doctor at all, a lot of times what's happening is they have made a realization or an assumption that you're on your hypoxic drive. So they want your O2 sat to stay below 94 or below whatever range they say, so that you do get that physiologic trigger to take a breath. She has both COPD and emphysema. Wow. Okay, so she probably gets some attention from 911 pretty regularly for trouble breathing, or she's at risk of it. All right. Anyway, continuing on, observe how much effort is required for the patient to breathe. Again, breathing should be effortless. So you should be able to breathe 12 to 20 times a minute, normal deep breaths, or at least moderately deep breaths without any effort. If you see signs that the patient is struggling to breathe, that's a problem. So a tripod position, which you'll see a lot with COPD and emphysema patients, any trouble breathing really, but especially those retractions. That's where you're like if you look at the gaps between the muscles of your neck, when you are struggling to breathe, you suck it in, you actually see those sections kind of pull themselves in a little bit. Accessory muscles, that is any muscle other than the chest wall and the diaphragm. So the neck muscles, if you're struggling to breathe, you'll see those muscles kick in, the neck kind of flares, you see nasal flaring. 2 to 3 word dyspnea, basically what that's saying is the patient can't say a whole sentence to you without having to stop and take a breath. And you can actually gauge how bad they are based on how many words they say. If they're cranking out 4 or 5 words at a time, okay. But if they're only able to get 1 to 2 words out, that's a major, major problem. They're far down that I can't breathe route. Sniffing position, that is more for babies than labored breathing, which is where, like, if you hear a sound, increased work of breathing and increased effort and rate. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meet the oxygen demands of the body. This can happen because of something going wrong with them. This can also happen if somebody works too hard with a medication that they're not supposed to work very hard with, like, say, a beta blocker. The ultimate result of respiratory failure, if it is, or is respiratory failure if it is not corrected. If they're going into respiratory difficulty breathing, respiratory failure comes up next, and then that basically is respiratory arrest. All right, your circulation. This is either your third or first step, depending on what your level of consciousness is. But there's 2 things you're going to search for. You're going to look for their pulse, and you're going to make sure that they're not losing their blood. The mental status you've technically already covered, and the skin condition, we'll talk more about that when we get into shock. But if they have good perfusion, their skin's going to be warm and pink, right? Because that means that all the capillaries in the skin are getting blood like they should. If something's going wrong, and say they lost blood, either internal or external, the body is going to shunt their vessels down, starting at the fingertips and working its way toward the core. And same with the toes. The blood vessels in the toes will start to constrict, and basically what the body is doing is it's trying to make it to where the blood stays where it matters, which is in the head and the chest. If you don't get blood flow to your fingers and toes, that's no big deal. You can get that back later. But if your heart's not getting it or your brain's not getting it, then nothing else matters. So skin condition can tell you a lot about somebody's circulation. If they are going into shock, if they're going into some kind of circulatory issue, the skin's going to lose that blood flow, and then it's not going to be pink anymore. It's going to start to turn white, and then or pale. You'll hear pale, cool, because without that blood, the skin starts to cool off, right? That's where a lot of our heat comes from, is our blood flow. So your skin turns cool, it turns pale, it gets kind of clammy, which is where it gets a little moist, and the fluid that is there is no longer staying in the blood flow. It's starting to come out and seep through the skin. Those are big signs of shock. That's one of the things, when you see skin condition, you're basically determining shock. Assess your pulse. What's our pulse rate supposed to be for an adult? Anybody remember the range we talked about was? Close. Y'all are all on it. At least y'all all got the top number. So 60 to 100 is what I go with. 70 to 100 is fine. 80 to 100, the low end of that, you will find a lot of patients sit below 80. So I don't want you to get caught into the bradycardia rhythm too much, but 60 to 100 is a good range. 50 resting, especially if somebody is active, right? The more cardio you do, the less your heart has to work when you're not doing anything. So your resting rate's going to lower. But yeah, 60 to 100 is about the range that you want to be at. If your patient is alert, we typically check their pulse in the wrist, which is the radial pulse. If they're unconscious, or if they're altered level of consciousness, or anything, their skin seems weird, that kind of thing. Hey, some people's are up there, especially women. Women have high pulses. Anyway, if they're unconscious, we're not going to bother with the wrist. Think about when you do CPR, right? If they're unconscious on the ground, you don't check a radial. Probably not going to have it. You go straight for the carotid, which is in the neck. What I want you guys to do, and this is just my own Robert Roy EMT instructor, if I can pass something to you, check them both. All right. If you have it in the wrist, you have perfusion. If you have it in the pulse, or I'm sorry, in the neck, you have a pulse. All right. That's 2 different things you're checking there. If you're worried about shock, one of the first things to go is going to be that pulse in the wrist. It also saves you time. If you go to check somebody's wrist and they don't have it, now you got to go and check the pulse in the neck. And so That just eats up time. You're still in your primary assessment right now. So two fingers on the wrist, 2 fingers on the neck. Hopefully you feel them both. And if you don't, it gives you an immediate idea as to whether or not you're dealing with something that could be like shock or another life threat. 100 is not considered tachycardia in situations right now. 100 is the maximum. And just like in breathing, there's a gray area. So it's 100. The way that I always look at it is 60 to 100 plus or minus 10. So anything over 110, you could be considered tachycardic. Now, whether that's a problem or not just depends on your patient. Some patients have a high heart rate, it's no big deal. Same thing on the other end. If they're 50, even though 60 is your minimum there, if they're 50, that's fine. If they have 40, well, that's a little low. But I mean, if this guy's a marathon runner, he just might have a 40 for a pulse. It's, you look at again, it comes down to your patient. Your vital signs are guidelines. They don't have to be exact. So if we give you, and even in the registry, if I give you a pulse that I expect you to have a red flag for being either too low or too high, it will be significantly too low or too high. It won't be very close to the range that you're looking at. So if I said 110, you're on the upper range of it, but that's fine. If I told you somebody had a pulse of 200, well, that's a little bit different, that kind of thing. We already talked about skin condition, skin color we talked about. Skin temperature, our bodies are normally at 98.6. So if you touch somebody, if you take the back of your hand and you put it on somebody's head, and if you're not sick and they're not sick, do they feel hot or cold to you? They feel normal. You actually don't feel warmth from them. You just feel the contact, but you don't really feel any warmth. If you touch them and they feel cool, that means they're colder than 98.6. If you touch them and they feel hot, that means they're higher than 98.6. But by actual touch, you really don't feel, your skin doesn't recognize 98.6 or anywhere in that 1 degree as being hot or cold, because it's so close, it matches you. So like you'll feel the presence of it, but you really won't feel the warmth. Skin moisture, dry skin is normal, but consider your surroundings. If you're dealing with somebody with heat exhaustion or something, or borderline heat stroke, dry skin is not normal. When they should be sweating and they're not, that's different. But under normal circumstances, somebody sitting in their recliner, their skin can be dry. Skin that's wet, moist, or excessively dry can suggest a problem. Again, consider your surroundings. Cap refill, I hate it. There's so many things that change it. We do the 2-second rule. That's fine. You can check cap refill, but don't live and die by that 2-second rule. If it's cold, it's going to be more than 2 seconds. If it's a female, it's going to be more than 2 seconds. If it's a 40-year-old, it's going to be more than 2 seconds. It just, if you're in Colorado, it's going to be more than 2 seconds. But what you can use as far as trending, if you check your cap refill in your primary assessment, great. And if it takes 3 seconds, all right, that's fine. But you check your cap refill again 5 minutes later and it's 6 seconds, that's a problem. So you can use it for trending, but don't get hung up on that 2-second rule. If you check cap refill, I tell you it's 3 seconds long, that's fine. It shows you how to do it. All right. Assess and control external bleeding in trauma patients. We will go over this at great length when we get to the actual trauma module. But this is where you're going to fix the hemorrhages, is what this is getting at. So if they have an arterial bleed, say they chop their hand off and their radial artery is shooting out blood with every pulse beat, we need to fix that. This should occur before addressing airway or breathing concerns if it's a hemorrhage like that. Bleeding from a large vein is characterized by a steady flow of blood. Bleeding from an artery is characterized by spurting blood. You got to think, the pressure's higher on the arterial side because you're closer to the heart. So every time the heart beats, it shoots blood, like Spider-Man, just across the room. But your veins are on the other side of your capillary beds. So there's no like spurting pressure on that side. It's just the pressure of the blood flow. So it just kind of flows out. Doesn't mean it's not just as dangerous. It just means that you're not going to get hit from the other side of the room with it. And sometimes, because I've actually seen this, somebody will nick an artery, and because those arteries are elastic and they're kind of stretched out, they're designed like that so that they can move with the flow of the blood. The artery actually kind of sealed itself off. So, I mean, of course, and if you've watched Black Hawk Down, you know that the guy's femoral artery shot up into his groin, which doesn't do you very many favors either. But it just kind of depends, and that's your assessment. You'll figure that out when you look at your patient. But you're going to fix the life-threatening bleeds here. The paper cuts, you don't worry about. Small venous arteries that, yeah, he's bleeding pretty good, but I mean, that's not going to be 5 liters in the next minute. You can let that one go. Femoral is pretty much game over. If you lose that artery, it's up in the groin. You're not going to find it. You can try, but it's not going to work. I had a complete amputation in MVA this weekend and nearly 0 blood. 0 external, I'm assuming? Usually if you amputate something, there's going to be some bleeding. So in other words, all right, let's say you lose your leg mid-thigh. You may not lose a whole lot of blood because your femoral artery is going to retract up into your groin and all your bleeding is going to be internal. That blood's going to start to pool up inside of you, so you really don't lose any blood. But, it's the right arm. How far up? Oh, wow. So, okay, so same thing though, that far up in the arm, the brachial artery probably retracted into the shoulder, and then the bicep and tricep sealed it off. The blood just stayed in the cavity. He's lucky, because depending on where it cut, the muscles might have actually crimped off the artery, so he didn't bleed. Okay, anyway, getting on to this. Yeah, treat your life-threatening bleeds. Jeez, it's getting late. Before you bother with your airway and breathing. If they're hemorrhaging out, let's say they lost a foot and they're spurting blood, it really doesn't matter if they're breathing if they have no blood in their system to carry the oxygen around. So, and plus you got to think, you can hold your breath for a little bit, but depending on how much blood they're losing, that's much more time sensitive. So even though I know we harp on ABC, you're still going to, in that general impression stage where you take an overall look at your patient and go, holy crap, he's missing a foot and there's a whole lot of blood on the ground. Go ahead and fix that and then continue your ABCs. Controlling external bleeding, they actually took out a step because it was a complete and utterly useless waste of time. So what we do now is we do direct pressure, where it's just like if you see somebody gashed at the wrist, you take your gloved hand and immediately put pressure on the wrist. And you hold that, all right? And you don't waste time trying to get your 4x4s yet or anything like that. You start with your hand to stop the loss of gross blood, the gross being large amounts. Hold that down while you're digging into your medical bag with your other hand, getting your 4x4 or tourniquet if you need it or whatever it is to make a more permanent stop. All right, and if any of y'all have gone through stop the bleed classes in the past, or if you're EMRs, you probably remember the elevate, which is that is the complete and utter useless waste of time because I mean blood pressure negates that. How that ever got in the textbook, I'll never know. But if that worked, then the minute you stood up, you'd have a stroke. Apply a tourniquet if direct pressure is not quickly successful. In other words, if you grab if let's say it is a wrist, if you grab that injury and put pressure on it, and they are just bleeding right around your hand, like you're not even there, go straight to a tourniquet. And an obvious arterial hemorrhage is not something you're going to be able to control with a 4x4. So go ahead and put a tourniquet on that too. If they're shooting across the room, it's a tourniquet. Scan the body to identify injuries that must be managed or protected before the patient is transported. So this is basically when you're dealing with a traumatic event, you know you're going to have to put your patient onto a stretcher. That involves moving the patient, rolling them over, putting a board under them, that kind of thing. So you want to give a quick scan, make sure that their hips are looking like they might be able to sustain being rolled, that kind of thing. This is not systematic. It's not meant to really find anything nitpicky. This is just I'm gonna look at my patient. I see 2 arms, 2 legs. Everything looks to be where it needs to be. Okay, cool. All right, determine your priority for patient care and transport. Everything we do in this class is going to be a high priority, but not everything you do in the real world will be. Somebody that stubs their toes, not a high priority for transport. Some things are, though. So some examples would be if they're unresponsive, poor general impression, difficulty breathing, uncontrolled bleeding, responsive but unable to follow commands, severe chest pain, pale skin, complicated childbirth. These are things that you're going to want to go ahead and just say high priority for transport. So basically, if there's anything wrong in their head, if there's anything wrong in their primary assessment, so the ABCs, they're a high priority for transport. Paper cuts, not a real high priority. If a spinal injury is suspected or found on assessment, consider spinal immobilization. That is your C-spine. So if you suspect C-spine, go ahead and put a collar on them. They are getting away from using the long boards like they used to. Used to be we put everybody on a long board, but we've actually been killing patients by doing that. So we typically only use the long board as an intervention if they have lumbar back pain or hip injuries, that kind of thing. That's what those were really meant for, is to protect your mid and lower spine and your legs. Now, if you want to use a board to help move somebody, like first time I ever met Wesley, we were on an accident on the interstate and we had to get this guy out of his car. The easiest way to do it was to shove a longboard up underneath his driver's seat and slide him out onto it. We didn't keep him on that board because that wasn't what it was used for. Hey-o. We just used that board as a tool to get him out of his car. So in those cases, use the tools you've got. You're not using that as an intervention. But I will say this, one of the problems with the longboard is if you are going to use it as an intervention, the only person that can take them off of that board is the ER doc. So therein lies the problem. We have somebody with, say, scoliosis or something like that, and we put them on that board, and then they wind up suffocating because of their bone abnormalities, and that board is very unforgiving. Is it true they don't test longboard immobilization at registry? It's a optional skill now. So it is still there. In fact, I believe I put the skill sheet in your downloadable files just in case, because we may give it to you. But it's optional because they are getting away from it. Like I said, we found that those are causing more harm than good. KEDs are better, or just nothing at all. I mean, what's wrong with just let your stretcher? Your stretcher is rigid, but that padding helps out a lot. So, all right, the golden hour. Somebody asked me about this the other day, just view whiz thing. The golden hour is basically a goal that we have in every transport we make, that starts from the time of the injury, not the time you get there. Yeah, a lot of people got rid of longboards. Scoop stretchers. People will use those instead because they still have that gap between them that works just as good and is not as unforgiving as a longboard. Anyway, golden hour starts at the time of the accident, not the time you get there. If it takes you 20 minutes to get there, you're kind of behind the curve. You got 40 minutes to do your work, get them to a hospital. Places like down here, that can be difficult when you're 45 minutes away from the hospital and it took you 20 minutes to get to the patient. If you blow the golden hour, it's not that big of a deal. It is just it's a goal, is all it is. The best chance of survival is if they get some actual care within that hour. And then aim to assess, stabilize, package, and begin transport to the appropriate facility within 10 minutes. This is also called the Platinum 10. That one does start from your arrival. So there's really no reason if somebody is unstable, or if it's a traumatic call or whatever, and you're the transport unit, there's no reason why you should be on scene for more than 10 minutes. If you're non-transport, fire EMT that's not working the ambulance, sucks for you if it's more than 10 minutes, but I mean, that's not your fault. That's the transport unit. Transport decisions should be made at this point. Again, we're going to only give you high priority or critical patients, which means they're going to be high priority for transport. Some patients will benefit from immediate transport, others not necessarily. Diabetics, type 2 diabetics that you can fix with sugar, a lot of times they don't even need to be transported. You just fix them on the scene. They wake up, they eat some food, they're good to go. Transport decisions are based on the patient's condition, the availability of advanced care. Let me get to the right slide. The distance of the transport and the local protocols. Again, if you're 45 minutes from a hospital and your guy is like bleeding out, dying on the ground, and that he ain't gonna last very long. First of all, he needs to be high priority for transport. That goes without saying. But taking the truck may not be the best way to get him there. Get the helicopter out there, kind of thing. All right, it is now 8 o'clock. Take another 10-minute break. We'll get started on history taking, and we're doing pretty good. So take 10. See you at 8:10. All right, around about 10 after. I know I'm cutting really closer to 8 minutes than 10, but I'm gonna go ahead and get back on it. Start with history taking. So at this point, we've kind of had to make a decision. All right, we've gone through our scene size up. That's always the first thing we do. Once we get to our patient, we start with our primary assessments. Always the first thing that we do. Um, it's real easy, especially when I'm giving you, like if I, it's very easy for me to trip people up. I give you a scenario and I spend more time talking about distractors than I do about the actual issue. I tell you about his broken legs and how you see him laying on his stomach, and he's got all kinds of bleeding and his shirt's torn and you can see bone coming out of his ribs and all that stuff. And I can paint this really gnarly picture for you. And you'll go straight to it and skip the fact that he's not breathing. Or I may tell you that you have a conscious patient and I'll give you a scenario, and students are really bad about going, all right, well, let's see. All right, sir. And then they'll jump right into this, what we're about to talk about, history taking. I'm like, I know he's alert and talking to, well, I know he's talking to you, but there's a whole lot of stuff you still got to check, that kind of thing. Because we can tell, like, if you see an experienced paramedic or an EMT, if we walk up to somebody, we might immediately start asking them questions, but we do it in a different way. There are little cues, like, we'll shake their hand, like I said, or I might start off with an introduction and then ask them their name and everything. So even though I might go right to a question, I'm still getting that intro information. For you guys in the class, like I said, I want you to learn the checklist and hit it line by line. When you go out into the real world, you'll hit it line by line in your head, but you won't have to say it out loud, that kind of thing. And then you can kind of start to group things together to make what works for you flow better. But just remember that when you're doing this, especially for your evaluations at the end of the class, it's scene size up is first, hit each step. Primary assessment is first, hit each step. Or first when you get to your patient, second overall. Once you finish your primary, then you go into what I consider to be your secondary assessment. I want you guys to think of everything from here, with the exception of your reassessment, being in your secondary. And within your secondary assessment, you can pick and choose what you do first. You can bounce all over the place if you want to. I don't recommend it because you start to forget things. But you don't get penalized for that. So what I do is I put my vital signs and my history taking, they're not the same thing, but I kind of pair them together. If my patient is stable, I'll get those. And I can take that time on the scene. If my patient is unstable, I'm going to do a quick head to toe assessment, figure out if I need to move my patient. And if I do, how am I going to do it? Because if he's got a broken hip on the left side, I don't want to roll him onto it. If he's got a popped lung on the right side, I don't want to roll him onto his good lung, that kind of thing. So you'll do your head to toe, get him in the truck, and then you can do your history taking and your vital signs. And you can, go even further than that. You can be like, I'm going to make sure that I do my vital signs first because it's a medical call and I don't know what's going on. Or, this might be something more like an allergic reaction and I need to know his allergies. Or heart patient, I need to know his allergies. I need to know what medications he's taking before I can give him a nitro. So within your secondary assessment, you are in control of your own destiny, and you're going to find that you structure it a different way depending on what kind of patient you're dealing with. So you're never going to do it the same within the secondary for every single patient. A trauma patient is going to get a different order than a medical patient. One medical issue is going to get a different. You're going to see where I'm going with that. But anyway, so from here on, this isn't necessarily going in order, is what I'm getting at. We're going to talk about the sections, but the next section we talk about might be the first thing before history taking. History taking is where you figure out what your patient details are. And there's a couple of acronyms that we use. So you're going to want to be sure to document the following information: the date of the incident, the patient's age, race, gender, past medical history, current health problems, stuff like that. Past medical history does not mean that I don't know, did anybody watch House? Y'all see that one episode where they were kind of making fun of the patient? Where they got the girl to do the patient history, and like it shows her all of a sudden it cuts to her telling the house everything she found out about the girl's twisted ankle when she was in second grade, and how little Johnny used to beat her on the playground or something like that in kindergarten. All this stuff that had nothing to do with the patient's pregnancy. Make sure when you get your histories that it pertains to what you're dealing with. Because people will give you their entire life story. Investigate the chief complaint. The chief complaint is different from your general impression. Know that the chief complaint is not what you think is wrong with your patient. That's your general impression. The chief complaint is, why did they call you? All right. My chest hurts. I hurt my foot. Those kind of things. Those are the things that you're going to want to check. And based on what their chief complaint is, that's how you structure everything. So make your introductions, make the patient feel comfortable, and obtain permission to treat. All right. So that doesn't change. Ask a few simple, direct questions. Refer to them as Mr., Miss, or whatever. Now, obviously, use what they want to be used. And so what else? Like I said, when I introduce myself, I'll be like, "Hi, my name is Rob. I'm going to be EMT today. What's your name?" And they'll give me their name. I'm like, "Cool. All right. Well, what would you like me to call you?" Because sometimes it's becoming more of a cultural thing that if you jump straight to Mr. or Miss or Sir and Ma'am, you can actually offend people. And it's not even about the stuff you hear about in the news these days or whatever. People in the Northeast, it's an insult. It's not even about assuming an identity or anything. It's what the hell? Why are you calling me sir? You thinking I'm old or something like that? Like, no, I was raised in the South in the military. We say sir and ma'am. My bad, but some people don't like it. It's weird to me when somebody says Mr. Robert or Mr. Roy. It just sounds weird because I'm not used to it, but it doesn't bother me. But to some, it does. When you're dealing with the chief complaint, stick to the open-ended questions. That way, they're telling you what's wrong. Because if you walk up and they're holding their leg, you be like, "I see, yeah, your knee hurts, huh?" And then they're like, "Yeah," and then they're like, "Well, you want to know what the pain's like?" And you're like, "Oh, is it hurting underneath your knee?" Yeah, that kind of thing. And now you're guiding your patient.
Take it in the room. I'll take it.
If you're guiding your patient, they will only answer what you're telling them or what you're asking them. They're not going to answer. Hold on a second. There we go. All right. If you're asking leaded question or closing the questions, they will only answer yes or no what you're asking. So if there's something pertinent that they want to tell you that you didn't specifically ask, you may not get it. All right. So try to keep your questions open-ended. Open-ended being, so your patient tells you that their stomach hurts. You're like, okay, well, can you tell me where it hurts? Can you describe the pain to me? That kind of thing. And there's a couple of acronyms that we'll go over. Somebody put it in there a little while ago, OPQRST, which we're going to get to here very soon, that will help you figure out what those questions are. So if the patient's unresponsive, patient information includes about the incident can be obtained from family members if they're there, friends, bystanders, witnesses, medical alert jewelry. We talked about that. All right. If we're talking about pain, or any kind of discomfort, anything that a patient feels. So if you're, anything that you can't see, we use the mnemonic OPQRST. And that is onset. So what were you doing when the symptoms begin? Provocation. Does anything make the symptoms better or worse? All right. Quality is what does the symptoms feel like? You notice that these are open-ended questions. So quality would be, an example of that would be, well, it's a really sharp pain right here. I can feel it right here. All right. That's an answer that you would get for quality. Or, oh, it's like the whole stomach. It's all this area right here hurts. That's quality. And that's important because I think we talked about it in anatomy. If we didn't, I apologize. I'll talk about it now. Organs, which one do you think hurts worse as far as like whether it's sharp or diffused and kind of spread out? Do you think an organ is going to be a sharper pain, or do you think a muscle or inner lining of something might be a sharper pain? Okay, so we got a muscle. Anybody disagree? Okay, so muscles, organ, or inner linings, I kind of put those together because they're about the same. So y'all are right. It is the muscle. Donna, you answered that really quick. Do you want to take that answer real quick and explain why? Do you know why that is the case? You can talk if you got it. You can unmute.
I would say because the muscle is usually bigger, more used. They feel it more when they use. You really can't feel your liver per se versus
Okay.
your abductor muscle.
Okay. So yeah, it's not necessarily about the size, but you're on the right track. The organs in your body are not typically gonna feel things. Your body doesn't assume that you're gonna get punched in the pancreas, for example. So you don't really build a whole bunch of nerve endings there that tell you how that organ feels. There are nerves there that are pain receptors, but they're more spread out. So if your pancreas is hurting, if your pancreas is inflamed or something like that, the pain receptors that pick it up are further out. So the pain it's not necessarily going to be less pain, but it's going to be more spread out. Muscles, visceral linings, pleural linings, all those things, very different. Your body wants to know when something is going wrong with those areas. And so there's a whole bunch more nerve endings. Not only that, but that also helps to trigger, because if you think about your voluntary muscle, right? If you touch something hot, your body wants to know very quickly that it's hot. So it has more nerve endings. The more messages that get sent, the better. Um, so you're going to feel that more. You're going to feel like, oh God, it hurts right there. It's real sharp pain. Anytime somebody tells me that they have a real sharp pain, I kind of breathe a sigh of relief, because most likely that's a muscle or a visceral lining, some kind of inflammation there or something like that. If they tell me that the pain is kind of spread out in an area, um, that usually points to an organ. And like I said, don't confuse spread or diffuse with dull or not that bad. Anybody that's ever had appendicitis would tell you very quickly that that pain is excruciating, but it's not something that they could pinpoint. It's like the whole right upper area, or I'm sorry, right lower area is just on fire, hurts. It's like every nerve ending in that entire section is blowing up. But the pancreas isn't really that big. Um, Another thing, think about your heart patients, right? They have this pain in their chest. Sometimes it's in the center. They feel like they got something sitting on them. Pain radiates down the left arm. The reason it radiates down the left arm is because the heart points to the left side. So the heart's more on the left side than it is the right in most people. Some people have a deviated axis, but that's if you go to paramedic. Don't worry about that. Heart points to the left, so the deferred pain is a little bit closer to the left arm. So it gives you that feeling that your pain is going down that side. That's what that is. So quality helps you determine whether or not you're dealing with an organ or a muscle, so on and so on. Region and radiation. The chest pain going down the left arm is an example of that. If there's kidneys, they feel it down in their flanks, like around to their backside. That's what you're getting in this part. Severity is the pain scale, and like I said earlier, it's always a 10. It's always a 10. But try to get an accurate one. Let them know, like, look, your normal headache is a 5. Your migraine that you can't keep your eyes open, that's probably closer to an 8. And if you shot yourself in the face with a shotgun, that's a 10. All right. And then your timing. Timing has the symptom been constant, or does it come and go? You can also ask them how long it's been going on. Anything to do with that is what you're going to get in that part. Identify pertinent negatives. An example of pertinent negatives would be nausea and vomiting, right? Everybody always puts them together. You feel like you're going to throw up, and then you throw up. A pertinent negative would be vomiting without the nausea. So if you're just mid sentence to somebody and then you hurl across the room, um, that's usually not your digestive tract at fault. A lot of times when that happens, it's a head injury or something of that sort. So, um, That would be a pertinent negative though, right? Because that's two different systems, two very different issues, two very different treatments, that kind of thing. If you're expecting something and they tell you that they don't have it, that's a pertinent negative. Use a mnemonic sample. This is what you're going to do for everybody, be it trauma, medical, whatever. Know these, no OPQRST, no sample. Sample is your patient's actual history. So signs and symptoms for S, allergies, medications, pertinent medical history, not the complete story. Last oral intake and events leading up to the injury or illness. Last oral intake is important because if they have a food allergy, you can kind of get an idea that that might be what they did. Also, if it's a massive trauma, sample is a power tool. If it's a massive trauma, the only thing that fixes trauma is surgery, and with surgery comes anesthesia. So the docs are going to want to know if home dude just ate 3 pounds of crawfish right before getting into a wreck. Critical thinking and assessment. All right, you guys, your EMTs, you're above EMRs, you're a long way above, like I said, the lifeguard, the babysitter, that kind of thing. But you're not docs. So you're not expected to diagnose your patient. You're not expected to figure out, because you're not a walking lab. You can't do blood work, that kind of thing. There's some things that the hospital does that we don't. Getting troponin levels to figure out if somebody's having a heart attack, for example, is a great vital. That's a great number to look at, but we have no way of gauging that in the field. So we have to kind of think outside the box on some things and get ahead of it. Now, we could be wrong. So as EMTs, we treat the symptoms. We don't treat what we think it is. In other words, if I see somebody with COPD, I'm not going to give them a COPD treatment. I'm going to give them a breathing treatment because they're having a hard time breathing. Our job is to try to stabilize the patient, treat the symptoms that we can treat, and the questions that we ask, like your medical history, your allergies. Allergies is pretty big for some of the things that we give, but really, we're getting that information to pass on to the hospital because they're going to be the ones that have a whole new set of tools, but they need to know that stuff. And who knows, the patient might have been awake when you got there, but he's not awake when you get to the hospital. All right, so let's talk about alcohol and drugs real quick. All the fun stuff. Signs may be confusing, hidden, or disguised. People that work in law enforcement, you see drug addicts and alcoholics so much that when you start to see the signs of it, it's pretty much just like, all right, that's what I'm dealing with, is another drunk. But we've lost a lot of diabetics and other like medical issues that people have. We've lost a lot of people in the backseat of a cop car. And it's not the cop's fault. The cops aren't technically trained to be EMTs. Some of them are, but for the most part, your average cop is not an EMT. So they deal with what they know, and we deal with what we know. And I'll say this: cops have gotten a lot better as a career about if they have somebody that's not quite acting right, and it might be screaming alcohol abuse or public drunk or something like that. They'll still call out the ambulance just to do a quick checkup. You show up, check their sugar, everything was good. Maybe he's drunk. You show up, you check the sugar, and it's like 10 or something. Like, oh, he's not drunk. He's having a diabetic emergency, and then you can fix him. The signs can be the same across different things. Patients may deny having any problems. History gathered may be unreliable, and don't judge the patient. So that kind of goes into the burnout stuff we talked about in the past. The more you see it, the more you see the worst in society and stuff like that, the more you start to expect it. But when you start seeing it in everybody, it may be time to consider a new career. Be professional in your approach, even if they are high or drunk or whatever. They're still human beings. They still deserve the dignity. They might have done a bad thing, but that doesn't mean they're bad people. We had one in our area that ran through the weigh station, and they thought he was drunk. I was trying to ask if he was diabetic, and they were yelling, "He's drunk." Was the law enforcement was yelling it? That's sad. I mean, yeah, I guess sometimes it'll happen, but you run into that. You'll run into even people in EMS who know better. will be like, no, he's drunk. You know, it just, you can't assume, don't assume. If you find yourself doing it, consider a different career or a vacation or something, you know, get out of that mindset. Physical abuse and violence. If you see this, report it. We're mandatory reporters for a couple of things. Sexual assault is one of them. Gunshots is one of them. Follow your local state and protocols. But for the most part, I don't mean, because I can't say for every AHJ out there, but pretty much everyone that I've ever encountered or ever even heard of, there's mandatory reporting. Don't accuse. So just because somebody looks like they're being abused doesn't mean they really are. I know we talked about cultural differences in the past, how Chinese families as a culture, they did for even, a lot of them still do it. They do what's called coining. Well, if you just looked at a patient and you saw all these red marks and everything all over them, you might think that they're being abused. Really, what they're doing is that's a cultural attempt to fix whatever's wrong with them before they call 911. So, you know, don't assume, don't accuse, but if it is something that is definitely looking like it's abuse, or if it really like legit, like homie just shot that person, there's no mistaking that. Don't accuse, because what that does is that inflames the situation. After that, it's just bad. Now you're in danger. So just excuse yourself, like, I gotta grab something to the truck. On your way out, hit the radio. I need law enforcement on scene. That kind of thing. Sexual history. Consider all female patients who are able to give birth, and they are complaining of abdominal pain. Consider them to be pregnant, even if they tell you they're not. All right. I'm not saying that they're lying, but they a lot of times don't want to tell you, or they just don't know. So, as far as your care is concerned, just consider every girl that can have a baby possibly pregnant until proven otherwise. Questions to ask when faced with this pre-hospital scenario is, when was your last menstrual period? Are your periods normal? Not everybody gets a period every month. All right. Even the 20-year-olds, if you've got COPD, or not COPD, Jesus. If you've got, oh God, what is it? It's the PCOS. If a woman has PCOS, that can really mess with her monthly cycle. Her birth control can mess with her monthly cycle. She might be on, and here's why, I say some women don't know they're pregnant. You could be on birth control and taking an antibiotic, and that antibiotic will screw up your birth control. Now it's not working. You're at risk for pregnancy. Some people don't know that. So, like I said, just keep that in mind. If the patient's bleeding, how many sanitary pads or tampons have you used? Do you have urinary frequency or burning? And again, like I said, these questions can get kind of personal. So stay professional, keep their dignity. If you're asking this of a teenager, don't do it in front of her parents. You're going to get a lie on everything that might get her in trouble. So, like the question of, are you sexually active? Save questions like that for when they're alone in the back of the truck. You're much more likely to get the real truth. Is there a possibility you might be pregnant? Are you taking birth control? Inquire about urinary symptoms with male patients. So, is there any pain when you go to the bathroom? Do you have any discharge, sores, increase in urination? Has there been any trauma? Trauma to the male genitalia looks like a murder scene. There is so much blood, you'd think you chopped somebody's arm off. Have you had any recent sexual encounters? When appropriate, ask about the potential for an STD in all patients. All right. What do you think is the most common STD in the country? See who gets this. Not AIDS. It's not HPV. Oddly. Oh, I'm sorry. It's interesting that they say it's not HPV. It is chlamydia. Victoria Whittington, good job. So chlamydia is the most common STD, and I said in the country, but yeah, in the U.S., you're more likely to have chlamydia than you are to have HPV. Now that's impressive because over half the population of the world has HPV. They don't even know it. So I'm, close second to you, John, on that one. You're more likely to have it than you are not to have it. But in the US, the numbers are actually fairly low, mainly because we have a vaccine for that. All right. Talking about some special challenges, multiple symptoms, especially in older patients, because they're going to have whatever they call 911 for. Plus, they're probably going to have anywhere from 1 to like 6 different chronic illnesses that they're also dealing with. That's going to mess with your vital signs. It's going to mess with your interventions. It's going to mess with all kinds of stuff based on whatever medications they're taking for that. Prioritize the patient's complaints as you would in triage. So start with the most serious one. If they're complaining about a stub toe, trouble breathing, and like left-sided facial droopage or something, stub toe is not going to be at the top of your list. Anxiety. Consider the context of the situation and recognize that the observed anxiety may be a sign of a serious underlying medical condition. Remember, the first sign of hypoxia is anxiety. That's long before blue lips, long before hypoxia or anything like that. When their oxygen level starts to drop, the first thing to happen is the brain starts to complain. It's the biggest baby in the body. If the first thing to go wrong with either your blood sugar or your oxygen, your brain is the first thing to pipe up. So altered mental status, anxiety, that kind of thing, which you're going to see first. Frequently, anxious patients can be observed in emergency scenes that involve a large number of patients, such as during a disaster. They're not just worried about themselves, they're looking around them and going, oh my God, what just happened? And they're freaking out. Some anxious patients show signs of psychological shock, such as pallor, diaphoresis, which is sweating, shortness of breath, numbness in the hands and feet, dizziness, loss of consciousness. Some people will pass out because they're freaking out too bad. And anxiety can be an early indicator of low blood glucose, shock, hypoxia. Anger and hostility. Every patient encounter has a high potential for verbal hostility, especially if they don't want you there, or if whatever happened was attributed to anger in the first place, say like a domestic dispute. You could face this. Friends, family, or bystanders may direct their anger and rage toward you, especially if it's a patient who's possibly dying, because remember we talked about the stages of death. It's not just the one going through the dying that's going to have those reactions. It's the people that care about that person as well. Remain calm, reassuring, gentle. Don't let them get between you and the exit. If the scene's not safe and secured, get it secured. If that's, call law enforcement or just back out if you have to. But if it's something that you can fix, then do it. If all you got to do is move a gun out of somebody's reach, that they're not threatening you or anything like that, but the weapon's just sitting there, move it to the other side of the room. That's perfectly fine. Intoxication. Don't put an intoxicated patient in a position where he or she feels threatened and has no way out. That's pretty self-explanatory. A lot of times they're not, their higher functions aren't there. Their critical thinking and everything's not there. So they tend to fall into some animalistic urges every now and then, whereas like if they feel cornered, they're going to lash out. You get those angry drunks, that kind of thing. The potential for violence and physical confrontation is high. Alcohol dulls a patient's senses, which would make it difficult for an intoxicated patient to inform you that something feels painful. Crying. There's no crying in baseball. A patient who cries may be sad, in pain, or just emotionally overwhelmed. Not everything is physical. Some people are criers. When stress gets too high for them, that's what they do. That's their response to it. So you may come across that. It may be that somebody's got a legit traumatic issue that you need to deal with, and you're trying to get information from them, but they can't stop crying because it was their dad's car they wrecked or something like that, and now they're worried more about what's going to happen when they get home than they are about their actual injuries. Remain calm. Again, reassure them. Don't give false hope if it's something that's like severe, but tell them, we're going to do the best we can. Maintain a soft voice, and look, do this when people are screaming at you too. something I learned in customer service was when people start yelling, lower the volume of your voice, because it's really hard to complain and argue with somebody when you can't hear what they're saying. They have to lower their voice to hear you. And a lot of times, as soon as they do that, once the volume turns down, the argument turns down with it. Depression is among the leading cause of disability worldwide, now that we've actually started to diagnose people with it. Some symptoms include sadness, but depression and sadness don't technically go together. So don't always look for that. A feeling of hopelessness, restlessness, irritability, sleeping and eating disorders, a decreased energy level. Remember, we talked about some other signs to look for in yourself, like loss of interest in things you used to find fun, loss of interest in sex, loss of interest in your stuff, giving it all away. Depression, the best way I've ever been able to describe it is it feels like you're trying to move through quicksand just to get through your day. The most effective treatment in handling depression is just being a good listener. Sometimes people got to get it off their chest. I don't know who's unmuted. Let me mute you guys again. There we go. Sorry, I thought I heard a car door. All right. Confusing behavior or history. So conditions such as hypoxia, stroke, diabetes is a big one, trauma, some medications and other drugs can alter somebody's ability to explain what's happened. Hypoxia is the most common cause of confusion because it's usually the first thing to drop. In older patients, it is not uncommon to encounter a patient who has dementia, delirium, or Alzheimer's disease. Some of these come with some time periods of lucidity where you can actually trust what they're telling you and stuff like that, but we don't. Sometimes it's really hard. Like you might need to have a family member there. Oh, no problem. Hey, if you got to run, you can always just catch the recording. But getting back on that, if your patient is lucid, you can trust their answers. Refer to your protocols as to whether or not you can get a refusal. All right. Sometimes some systems will say if they're lucid, you can get it. Some will say no because they may fall back into it and then they're right back in the same problem. But regardless, I would say just as a good patient advocate, if you're going to get a refusal for somebody having one of these issues, leave them in the hands of somebody who can take care of them, like a family member or something. Don't just leave them on their own to suffer alone. Limited cognitive abilities, keep your questions simple. All right. Use the KISS method. Try not to give somebody a paragraph just to ask a simple question, and limit the use of medical terms when you're not talking to medical people. If you're talking to another EMT or a doc, then use medical terms. That's fine. We expect that. But don't ask the 60-year-old grandmother if she's been tachycardic for a long time, because she's probably not going to know what that word means. In cases of patients with severely limited cognitive function, rely on the presence of family, caregivers, and friends to supply answers to your questions. Sometimes they're your best bet, but if you can get it directly from the patient, then do that. Cultural challenges we talked about in previous chapters. We've talked about Muslim families. We've also talked about Chinese cultural differences. You may run into that. If you're a male truck and you show up to a Muslim family and it's a female that's hurt, you go ahead and call a truck with another female on it, because they're not going to let you near her, no matter how bad it is. Don't use medical language. Again, to non-medical people, they may not understand. Gain the assistance of the patient's family or friends, and enlist the help of healthcare providers of the same culture or background. A lot of times that shared understanding, they can avoid a lot of missteps that you don't have to worry about. Language barriers. I actually had a call up in central Mississippi years ago. It was a 2-car head-on collision. One was a van with about 7 or 8, I forget, Mexican patients in it. Not one of them spoke English. Not one of them had an ID on them. I had no idea what their names were, had no idea about their information, couldn't ask them any questions. The only thing they kept saying was "ayúdame" over and over again, which means help me in English. I knew that much. but I really couldn't get any patient history from them because I had no idea what they were saying. There are apps out there that are specifically designed for medical providers where you see it, you select the language you want it to be in. It gives you all your questions in English so you know what you're reading, but when you press on it, it says it in Spanish or it says it in whatever language it's supposed to be in. And then they will, and the questions are designed for them to kind of like point at where they're hurting. So you may not know what they tell you in return if they use words, but if they hear the question and then point at their stomach, you know where to look. If you can get an interpreter, if not, determine whether the patient understands who you are. Sometimes they may understand you better than you understand them. It's interesting, most primary English speakers only speak English. A lot of people around the world that English is not their primary language, they speak their language, our language, and probably like 3 or 4 others as well. Keep questions straightforward and brief and use hand gestures. Be aware of the language diversity in your community. I know that we've got a lot of Spanish speakers down here. We have a lot of Arabic speakers in the Northeast. So, depending on where you're at, you may have just different pockets of communities from immigrants from different areas that speak different languages. Hearing problems, ask questions slowly and clearly. Use a stethoscope to function as a hearing aid. I've never actually tried doing that. That'll be interesting. Good way to lose your hearing, honestly. Learn simple sign language to help with communication. That's not a bad idea, but I mean, how many people do that? Use a pen and paper so you can write down your question, have them write it back to you with their answer. But like I said, keep in mind, a lot of times hearing loss, at least hearing loss attributed to aging, is not necessarily that they can't hear you. It's they can't hear you in the pitch that you're speaking in. So if you can raise or lower the pitch of your voice, they may hear you better. Just don't fall into the habit of shouting at people just because they can't hear you very well. Your visual impairments, identify yourself verbally when you enter the scene. They may not be able to see you, but they need to at least know who you are because otherwise you're stranger danger and they have no idea why you're there. It is important that you put any items that have been moved back where they belong. A lot of people that are blind, they know where all their stuff is. And so they don't expect the table to be in the middle of the room because it's never been there before. You don't want them to run into it. During the assessment and history taking process, explain each step in the vital signs assessment. Let them know, like, all right, I'm going to check your blood pressure. I'm going to put this on your arm. It's going to squeeze you. That way they know what you're doing because they don't see you pulling out your blood pressure cuff. They don't know you're about to do it. Notify the patient before preparing to lift. If you're going to move them, you can tell the other people with you, it's like, all right, we're going to roll you onto your left side. We're going to do it on the count of 3. 1, 2, 3. It's good for coordination with your partners, but it also helps somebody know what you're doing when, again, they can't see you getting into position for things. All right, so we got the secondary assessment. Let's go ahead and take our last 10-minute break here, since this is at a good transition point. Be back at 8:57 or 8:55, and then we will continue on and finish out for the night. All right, get back on this. We're going to start with our secondary assessment now. We're getting into the last lap of this chapter. This is a long one, I know, but so the secondary assessment, I really don't like how they've separated it off away from the vital signs and the patient history. Like I said, I like to group those into the secondary assessment, and then it just makes more sense because how you're going to order your secondary assessment is based on what's in front of you. If your patient's in stable condition and has an isolated complaint, like say they just sprained their ankle, you may choose to perform the secondary assessment at the scene, and you can just follow their chief complaint right down to the ankle and not have to start poking and prodding on their head. If the secondary assessment is not performed at the scene, it is performed in the back of the ambulance en route to the hospital. If you're not going to perform this at the scene, it's usually because it's not that bad of a call and you're just going to assess it as you go. However, there will be situations where you may not have time to perform the secondary assessment. If that's the case, like say you're only 3 minutes away from the hospital, that's not too bad. But it could also be because your patient's in such crappy condition that you can't get out of the primary, right? Where you're just sitting there fighting to maintain their ABCs the whole time, and that's as far as you get. You may have to continue to manage life threats identified during the primary assessment en route to the hospital, so like a cardiac arrest patient. The purpose is to perform a systematic physical exam of the patient. So we're talking about head to toe. The physical exam may be a systematic head to toe secondary assessment or an assessment that focuses on a certain area of the body. Like I said, if they just were out rollerblading and they fell down and skinned their knee, that's what you're going to focus on. Guidelines on how and what to assess during a physical exam are kind of broken down into 3 different areas. You've got inspection, which is where you're going to look at it, palpation, touching and feeling professionally, and then auscultation, which is where you listen to the sounds a body makes by using a stethoscope, typically listening to the breath sounds at your level. Different people in different parts of the industry will listen to their heart, will listen to stomach sounds, that kind of thing. But for the most part, you guys, I really want you to get used to listening to breath sounds, all right? Because that's part of your primary, in that you want to make sure that they are able to breathe properly. So we use the mnemonic DCAT BTLS when we're doing our head to toe. You're really this is your main mnemonic for trauma. All right. When you're going head to toe and you're looking at the injuries, the broken bones and stuff like that, this is the mnemonic that you're going to be looking at. You have D is for deformities, C is for contusions, A is abrasions, P is punctures, B is burns, T is tenderness, L is lacerations, and S is swelling. So learn OPQRST, get it to where you can just rattle it off. Like if I walk in the door and I say, all right, what's DCAT BTLS? You go deformities, contusions, abrasions, punctures, burns, tenderness, laceration, swelling, and bleh, then you take a breath. All right. I'm going to give you a little tip for when you do your hands-on at the end. When you get to this point of your assessment and you get ready to start your head to toe, it is perfectly acceptable and preferred, actually, I will give you that, because you're timed. Not a short time, but you'll be surprised how fast you eat up the time in your assessment when you're actually having to actually do the interventions like they want you to do now, and actually taking the vital signs instead of just saying, what's my blood pressure? Instead of poking on the head and saying, I'm checking for DCAT BTLS, which stands for blah, blah, blah. And then you go into the neck and say, I'm checking for DCAT BTLS. And then you go to chest. You know what I'm saying? Just tell your evaluator right out the gate, I'm starting my head to toe. I'm going to be looking for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling, and any other specific injuries that are specific to that area. And then you get started. So you can say, all right, I'm poking on the head. And you look up at your evaluator, and he's like, "All right, cool. You have some crepitus in the skull." And you're like, "Okay, cool. I'm gonna do my thing." And you move on to your face, and you look up at the evaluator, and he tells you, you already told him you're gonna look for all this stuff. So it saves you time when you do that. Oh, sample DCAT BTLS appears you will see a lot in here, a lot at the. Yeah. Oh yeah. No, they do. They beat it like a dead horse. All right. Compare findings on one side of the body with the other side when possible. So some things will give you a different you're going to have different things or one problem on one side of the body and there'll be something else on the other one. When you're talking about trauma, an example of that would be if they broke a leg, broke their femur, or dislocated their hip, something like that. When you put their legs together, one leg's going to be shorter than the other one. Tells you that the shorter leg has a problem in it somewhere. Some other issues, if you have different blood pressures, like they're either different pulse or different blood pressures, one on one side of the body than the other, is a sign of a thoracic aneurysm. These kind of things. And again, we will go into that in depth when we get to those chapters, but I just want you to just understand why you want to say, okay, well, I had this on the other side of the body. It should be the same on this side. If it's not, a lot of times that's an issue. Systematically assess the patient. The goal is to identify hidden injuries or identify causes that may not have been identified during your first sweep of the body. So you've done your first sweep in the primary, you assessed your life threats. Now this time you're going back through and you're actually paying attention to the things like the broken bones, CSF fluid coming out of the ears and nose, that kind of thing. Systematic. So, all right, I'm sorry, let me go on the right slide here. There we go. Your focus assessment is performed on patients who have sustained non-significant MOIs or on responsive medical patients. You can actually take the time to sit there and poke and prod at every little thing. That's perfectly okay. If they're unstable, though, you don't want to spend too much time. It would be considered a waste of time, and you really should be thinking about speed, like get them in the truck, get them to the ambulance, get them to the hospital. But this type of examination is typically based on the chief complaint. So if I told you that I hurt my knee, I don't want you to, and I told you it was my right knee, I don't want you poking around on my left knee, poking me in the stomach, looking at my ears and all that. That doesn't make any sense. So focus on the chief complaint. The goal of a focus assessment is to focus your attention on the body part or system that's affected by the priority problems. Like I said, basically, just if they tell you that their ankle hurts, that's what you're going to focus on. So for your respiratory system, expose the patient's chest. Look again for signs of airway obstruction as well as trauma to the neck and or chest. You can consider this basically going back and just double checking to make sure that you didn't lose any intervention that you might have done during the primary, and also that the patient didn't regress since you did the primary, because you might have got to them, say it's a burn patient, you got to them pretty quick, their airway wasn't bad, but as that airway starts to inflame and fill with water, 10 minutes down the road, they don't have an airway anymore. Inspect the chest for overall symmetry. You should have equal rise and fall on both sides of the chest. If one side is rising more than the other one, it's usually a sign that one of the lungs is either popped or you're getting blood into that side of the chest and it's not allowing the lung to expand, that kind of thing. Measure the respiratory rate, chest rise and fall for tidal volume and effort. Because remember, none of your vital signs are just a number. There's got to be some context to that number. Look for retractions, trouble breathing, increased work of breathing, that kind of thing. Assess the patient's breathing by watching the patient's chest rise and fall. Listen to breath sounds with the stethoscope over each lung and do it high, high, low, low. All right, get an upper lung sound, lower lung sound on each side of the chest. If the patient is unconscious, feeling for air through the mouth and nose during exhalation, basically what that's saying, that's actually on your next slide, isn't it? No, it's not. What that's saying is that if they're unconscious, we used to call it look, listen, and feel. We basically, you're going to get down kind of close to them and you're going to look for the chest rise and fall. You can put your hand over, don't cup it, but like put your hand about an inch away from their mouth and nose and see if you can feel some air movement. That kind of thing. It's a real quick and easy way to tell if somebody's breathing. When assessing breathing, obtain the following information. First of all, we need a rate. All right, hopefully it's between 12 and 20. If it's an adult, children breathe faster. Remember, 15 to 30 for a child, 25 to 50 for an infant is the easy ranges that I remember. But 12 to 20 for an adult. Count the number of breaths in a 30-second period, multiply by 2. I would almost, especially if they're unconscious or critical, count for 10 seconds, multiply by 6. All right. You should at least get 2 breaths in that 6-second span, or in that 10-second span, rather. All right, measure their respiratory rhythm. If the time from one peak chest rise to the next is fairly consistent, then we call that regular breathing. If it seems to kind of change and change significantly, then that's irregular. We already change. I mean, even just me sitting here or you sitting there listening to me, whether you fell asleep or not, your breathing rate's going to change. When we start to get tired at the end of the day, our breathing starts to get shallower and shallower and slower until, because our body's like, hey, I'm going to start working my way to bed here. And then, okay, we're not going to bed. All right, yawn. Yeah. That resets you. And then you start breathing normal, and then your breathing gets a little bit slower, a little bit more shallow. Your body's trying to say, hey, man, it's time to go to bed, but you're not going to bed. So what do? You yawn again, and you reset the process. So a little bit of irregularity is fine. But if somebody goes from breathing 50 times a minute to 10 times a minute, and then back to 50, and then down to 12, and then up to 30, and everything, that's not normal. All right. Your quality of breathing. So we want to make sure that these are good, right? Normal breathing, you shouldn't really hear it without a stethoscope. If you hear a bunch of grinding, like gears, shouldn't be a thing. You shouldn't hear wheezing, shouldn't hear what we call rails, crackles. If you're hearing what sounds like Rice Krispies every time they take a breath, that means they've got fluid in their lungs. That's a bad thing. Wheezing means that their airway is constricted on the upper end, so the bronchi are constricted. And then snoring means that their tongue is in the way. So that's what we do the head tilt chin lift for. For their depth of breathing, they should be enough to get rise and fall out of the chest is what you want. That's the easiest way to say that. So you're going to just look for equal rise and fall of the chest. Yawning is contagious. How many people did I make yawn when I did that? All right, so as you can see, yeah, I had to get at least one person. As you can see, they're checking breath sounds on both the back and the chest. You don't have to do it that way. It's whatever is easier for you. Sometimes, though, you may have to, like if you try the chest and you don't hear it, try the back. But you want to try to get at least some good breath sounds, or if they're not good, at least you know what you're hearing, and then you can do your appropriate treatments. So we listen for normal breath sounds. Snoring, again, is a tongue. So we'll fix that with an OPA or an NPA. Wheezing breath sounds are usually upper airway constriction with the bronchioles or the trachea. You'll hear that a lot with asthma patients. You have crackles, which is like Rice Krispie. That's basically air moving through water pockets. So that's fluid in the lungs. And you have rhonchi and stridor. When we get to boot camp, I'm going to play all those for y'all so that you can kind of get an idea what they sound like. You can YouTube it if you want to get a head start on that, but we'll go over breath sounds in basic so you can hear it, in the boot camp rather, so you can hear it. You don't have to be a master of breath sounds. The big thing is to know what's not normal. All right, and then the big ones are the upper respiratory, like the snoring, because that's what you can fix. You can kind of fix the crackles, but not really. You start getting into paramedic and higher level or advanced EMT and paramedic level stuff, because you got to start giving like nebulizer treatments and everything for that. All right. Cardiovascular system. So look for trauma to the chest and listen for breath sounds. Consider the pulse and respiratory rate and the blood pressure, right? So you're going to get your vital signs. Pay particular attention to the rate, quality, and rhythm of your heartbeat. Consider your findings when assessing the skin. If the skin is cool and clammy, then you can kind of expect the cardiovascular system to be struggling as well. Be it that it's a faster pulse or higher blood pressure, that kind of thing. I already said that. Check and compare distal pulses to determine any right and left side differences. So again, I mentioned an aneurysm earlier. Basically, think of like an egg in the side of a tire. It's a weak spot. That's what an aneurysm is. And depending on where on the aorta it's at, it could be causing some turbulence that slows down the pulse that goes to one side of the body. Obviously, it doesn't do this if it's an abdominal one, but if it's up high enough, you can actually detect it by feeling a pulse on both sides. If one is diminished or slower than the other one, that means something is blocking the blood from getting to that slower side, that's not blocking it to the other side. And usually it can either be a clot, it can be an aneurysm, something like that. So that's a big sign. It's a big way to figure out what you're dealing with. And there's not anything you can technically fix in the field, but you can call a helicopter for them, get a paramedic on scene for them, get them figure out what hospital you want to go to. Because like I was talking with Wesley about it, not everybody's going to go to the nearest ER. Not everybody's gonna skip the nearest ER. It just depends on what you're dealing with. All right, so for your pulse rate, let's see. Oh, we already talked about that. Pulse rate for an adult, we already talked about. The normal rate is 60 to 100. All right, and then that pulse climbs as you start getting into the peds and the infants. So to obtain the pulse rate in most patients, you should count the number of pulses for 30-second period and then multiply by 2. I'm still going to stick to the 10-second period. I want you guys to get 10 seconds to be your magic number. All right, pulse for 10 seconds, multiply by 6. The reason being is because in certain things like CPR, your magic number is 10, right? No more than 10 seconds for the pulse check, no more than 10 seconds for breathing, blah, blah, blah. If I start giving you a whole bunch of different time frames that don't really matter, it's just going to throw you off. So check your vitals for 10 seconds, multiply by 6, that gives you your minute range. A rate that is greater than 100 beats a minute is described as tachycardia, but that's not always a bad thing. Some people just hang out that high. Same thing on the other end. If they're under 60, they're considered bradycardic, but it's not always a bad thing. It just depends on your patient. For your quality, if the pulse feels of normal strength, you should describe it as being strong. If it's stronger than normal, we call it bounding. All right, so if it's like really jumping out at you, it's bounding like a deer. And then if a pulse is really weak or it's hard to feel, then we call that weak or thready. I don't. You killed baby. What was that? Was that Tommy Boy or what was the other one? Tommy Boy or Black Sheep? Where they hit the deer and then the deer woke up in the back of the car. It was Black Sheep. Okay, I couldn't remember because I think both of those movies they were kind of traveling around or something. Yeah, I know, right? I miss Chris Farley. His movies were hilarious. All right. Anyway, getting back on it. So pulse rhythm. Determine whether the rhythm is regular or irregular. Even if somebody is coming down from, say, like a run, their rhythm is technically going to be irregular, but that's not kind of what we're looking at. Just because somebody's rhythm is slowing down, that's okay. What we're looking for is if you feel like a bump, 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 something like that, where it's just there's no order to it. That would be an irregular heartbeat that you would detect. It gets a little bit more in depth than that when you go up to the higher levels, but for an EMT, there's really no way for you to get it any more than that. All right, my headphones are dying. Let me switch to my regular mic. Hold on a second. All right. Can y'all hear me?
Yes.
Perfect. Okay.
Yes.
Just wanted to make sure it all swapped right. All right, get back on it. So blood pressure. We can tell a whole bunch of crap from blood pressure. If I had to pick one vital sign that I wanted somebody to give me, it would be the blood pressure. There's so much. If you really take some time and study what your arterial pressure is and what your pulse pressure is, all that stuff, that is some serious. You can get a whole lot of information from that. Blood pressure is the pressure of circulating blood against the walls of the arteries. It is in 2 numbers. The top number is the bigger number. The bottom number is the pressure that's just constantly there. So, just you having blood in your system is going to put pressure on your arteries. That is what your diastolic number is. It's the bottom number. Every time your heart beats and it pushes blood through the part of your arm where you're checking the blood pressure, it's going to raise the pressure in that artery for a minute until the blood passes by it. That is your systolic blood pressure. That's the pressure that's exerted with the heartbeat. And there's so much stuff you can get from this. So if the blood pressure rises, it could mean that your body is adjusting to shock. If your blood pressure drops, it could mean that your body is failing to adjust to shock, or you're losing blood, something like that. So a loss of blood, loss of vascular tone, problem with your pump being your heart. Those are issues with that. So it says right there, decreased blood pressure is a late sign of shock. If you're dealing with shock and their pressure is already dropping, that means you're way behind the curve in trying to fix that. You can also tell information from how close those numbers get together or how far apart they get from each other. I will go over that later on. I'm not going to get too far off into geek land with it tonight, but like I said, I'm a cardiology nerd, and blood pressure is up there with it. I've learned a lot about it and what that means, and it's good stuff, even at the basic level. We will touch on that more as we go, but if I drop it all on you tonight, it's not going to make sense. I'm going to lose everybody. So we'll save that to when we get to certain medical issues. Anyway, we talked about your systolic and your diastolic numbers and what they mean on this slide. A blood pressure cuff with a gauge, which is called a sphygmomanometer. It's a very large word. Is that on your slide? No. Sphygmomanometer is what we call our blood pressure, or that's the name for our blood pressure cuffs. But we have your outer cuff, an inflatable wide bladder, which goes usually on the antecubital side of your arm, a ball pump with a one-way valve, and the pressure gauge calibrated in millimeters of mercury. So if you've ever seen it written, it's mmHg when you're writing out your blood pressure. Also, if you're using this, don't give anybody an odd number for a blood pressure. Those gradients are even numbers only. And a lot of times we kind of know when people are fibbing their numbers by if they give us odd numbers with a manual blood pressure cuff. So the way that it works, and we'll go over this in the boot camp, but you're going to put it on their arm, position your stethoscope, inflate the cuff until you no longer hear a pulse passing through that artery, and then slowly deflate the cuff. When you start to hear a pulse, that's your top number. And you will continue to hear a pulse as it deflates until the cuff loosens up so much that you no longer hear it. Blood's flowing like normal. Whenever you no longer hear a pulse, whatever that gauge is at, that's your bottom number. All right, so here's your blood pressure ranges. Remember, we use hypo for low and hyper for high. So hypotension is low blood pressure. Hypertension is high blood pressure. Now, high blood pressure in itself is not an emergency. However, if you go from a certain blood pressure up to a certain amount within a certain amount of time, that becomes what's considered a hypertensive crisis, and that's an issue in itself. That's not something we can fix, but it is a good thing to know because that's something you're going to want to tell a paramedic or the doctor if you don't get a paramedic out there with you. For your neurologic system, the neurologic assessment should be performed anytime you are confronted with a patient who has a change in mental status, possible head injury, stupor, dizziness, drowsiness, or syncope. Evaluate the LOC and orientation to determine the patient's ability to think, especially if you think you might want to get a refusal or ask him any questions. If they're not in the right mind, you can't trust what they tell you, and you really can't get them to sign anything. Use the AVPU scale in your primary assessment. When you get down into this part, though, we're going to switch over to the Glasgow Coma scale, which is right there. It is. It's the last one on that slide. All it is it's a 15-point scale. You get 3 for showing up. All right. A rock, the table that I'm sitting at, gets a 3 on the Glasgow Coma scale because the smallest that the numbers go is a 1. But couple different things that you're going to check, 3 different columns. And it should hopefully total up to 15. If it totals 13, 14, that's not good, but it's not that bad. If they're under 13, they're automatically considered a critical patient and there's some serious neurologic issues going on. But at 13 and under, you're going to see that too. They're going to be drowsy. They're not going to be talking to you right, that kind of thing. But the GCS scale uses your patient's eye opening, verbal responses, and motor response. So are their eyes tracking you? Do they look at you when you walk up to them? Or are they just kind of like dazed off looking at something else? The verbal response is basically how are they answering your questions? And the best motor response would be like, can you shake their hand, for example, or hey, smile for me if it's a stroke patient, that kind of thing. So your pupils, this is a neuro check. This is actually a vital sign, but you can do this in your primary. It's okay to get this early on. What we'll do is you will take a pin light and you'll shine it into one eye. Now, let me ask you this. If I shine the pin light into a patient's left eye, which eye am I looking at? The left eye or the right eye? The right eye. Good. All right. So why am I not looking at the left one where I'm shining the light?
Because the one you're shining the light in is automatically going to react. You're looking to see if the other one is going to react.
Right. Good. So what we're looking at, we call it PERLA. All right. So pupils are equal and reactive to light, equal responsive and reactive to light. So if I shine the light into one eye, I want to know if the other eye is going to react because it should. It should constrict just like the one with the light, even though there's no light shining into it. They should operate in tandem. In the absence of light, your pupils get dilated. All right, it means they get bigger so that they're taking in more light, which you can see here in the bottom left. The top center is constricted, so if it's a bright room, they'll constrict down to keep a good amount of light inside of your retina or inside of your eye. And then unequal, where you've got one that's kind of constricted, one that's more dilated, that's a sign of a head injury. If you see that, that's an issue. They should be in tandem. A small number of the population exhibits unequal pupils. So you can ask them, like if you look at them and they're unequal pupils, which is a sign that they have a head injury, but they're talking to you like normal. And then it's one of those things that just doesn't quite match what you're expecting. Ask them, like, hey, is it normal for you to have unequal pupils? They'll tell you. All right, so depressed brain function can be caused by an injury of the brain or the brainstem, trauma or stroke, brain tumor. And again, we're going to get into this more when we get into the actual TBI chapter. So I don't want you to go too far into these. Oh, wrong way. But this is the acronym that we use. So pupils are equal and round, regular in size, and reactive to light. That's what PEARL stands for. Anybody in the medical field, if they see that you wrote pupils are PEARL, that means they know that you did a neuro check using the pupils and everything was normal. All right, neurovascular status. So you're going to perform a hands-on assessment to determine sensory and motor response. Check bilateral muscle strength and weaknesses. We do this for a lot of our stroke patients. You can have them put both hands in front of them, smile, that kind of thing. Squeeze your hands, use their feet to press down on your hands, that kind of thing. And you're checking their ability to control their muscles, not just their strength, but also their muscle tone. And you're going to compare the distal and proximal sensory and motor responses on one side with the other. If you're doing this in your head to toe, we call it PMS, pulsed motor sensory. So when you get down to the hands and the feet, you're going to kind of squeeze your hand and look at the evaluator and say, do I have good pulse motor and sensory function in the hands? Same thing with the feet. If it's a real world thing, there's not going to be an evaluator standing over you. You're just going to look at your patient and say, can you feel this? That kind of thing. That is something that we do because it may not be, the extent of their injuries may not be very easy to see. If you get into a car wreck, but you pinched a part of your spine, your patient may look normal at a glance, but they can't feel something. That can be an issue. So that's one of the best ways for us to check it. Your cord is not just one solid cord. You have your you have the inner cord, and then you've got like an outer sheath, and you've got nerves that run down the anterior side, nerves that run down the posterior side, nerves that run down the middle. And depending on what part of the cord gets pressure on it, you're going to lose those particular nerves. And at the EMT level, it's not so much that you know which ones are which, but just know how the cord is designed, and that's why we check those sensory and muscle function in the hands and feet. And you tell that to a paramedic, and he's like, "Oh, okay. Well, if that's what they're missing, then it must be this cord issue or something." Your anatomic regions, you're going to break the body into sections when you're doing your head to toe. So we start with the skull and the scalp. Then you work your way down the face. So you're going to check their eyes, their nose, cheekbones, mouth, ears, all that stuff. You're basically getting nitty gritty on this part. You're going to be looking for any CSF, which is cerebrospinal fluid that may be coming out of the brain cavity. Looking for blood, looking for broken teeth, anything that may clog the airway, that kind of thing. If you don't see anything, then great. Then we move on to the neck, which, there we go, head and neck and cervical spine. So you're going to check your jaw, check the mouth, any unusual odors in the mouth. If they are having GI bleeds, you're going to have a massively nasty smell. You're going to check the neck. At this point, there's not a slide for it for some reason. So we will go back. With the neck, we check for three things besides your decap BTLS. We check for step off of the spine, right? So you're going to kind of reach behind on the back side of their neck, and you're going to just feel your fingers down the cervical spine to see if any of those vertebrae are popped out of place. We check for jugular vein distension, which is on the sides of the neck. So you normally won't see them. Like, the veins aren't that easy to see unless you're really, really looking for them. But if they get distended because blood flow is impaired, they will stand out really, really easy, and you can see them from the other side of the room. And then we're going to look for what we call tracheal deviation. So if you think about it, everybody's trachea runs straight down the front center of their neck. But if they, if let's say you pop a lung, and all the air that's supposed to go into that lung is now escaping into the chest cavity, and it's not, you can't breathe it out because your lung's not functioning right anymore. All that air is going to start to it's going to keep building and building, and it's going to start pushing up against your other lung. As it does that, that lung's going to push to the outside of your chest, and your trachea is going to start to shift with it. All right, and that lung's going to be dragging it along. So if you see somebody with tracheal deviation to the left side, that tells you that their right side has got major problems, and there's not a lot you can do about that. You would definitely need to get a paramedic on scene for a needle decompression or something of that sort. Moving on down to your chest, you're going to inspect, visualize, palpate, looking for your decap BTLS, watch for equal rise and fall of the chest, and you're going to look for abnormal breathing signs. The real big thing is that you want to make sure that we don't have any sucking chest wounds, flail segments, unequal rise and fall of the chest, that kind of thing. And again, we're going to go into that more when we start talking about trauma, but I'm just letting you know, like, these are some things that you're going to want to see. For your abdomen, we palpate for tenderness, rigidity, and patient guarding. If the patient is like holding themselves, like they're hugging themselves, that's a problem. It usually means that either one of their organs has failed, or they might have, depending on if it was traumatic or not, they may have an evisceration. It could be any couple of things. We do break the abdomen into 4 quadrants. I think I said this in chapter 6. You know, you have your left upper, left lower, and then the right ones as well. If a patient says that one of their quadrants is hurting, like if they're pointing to their right lower quadrant where the appendix happens to be, don't start there. All right, that should be where you end. So if they're saying right lower, be like, okay, I'm going to check the rest of your abdomen, and then we're going to get onto that. Because if you start pressing on where it's already hurting, they're going to hurt so bad they're not going to feel anything else in the other ones. You may miss some things. Your pelvis, you're searching for any sign of broken hips, so you can check their hips for stability. See if you hear any crepitus, which is bone against bone grinding. You're going to be looking for any injuries to the genitals, priapism, which is if they have a head injury, the male will get an erection. That's called a priapism. So we check for that. And then we get onto our extremities. Now, if you're already down there, do the lower extremities first. All right. Check the upper leg, then the lower leg, check the knee. And what I do, especially if I'm doing this, is a rapid trauma assessment. I will work my way down. When I get to the leg, I'll check the upper leg and the knee. If I don't see any deformities at that point, I don't worry about the lower leg. It's not that important. All right. Same thing on the other leg. I'll check the upper leg, check the knee. If there's no deformities, I'm good. If I see deformities, if I see any reason to think that I might have problems with the leg, then I go to the foot and I check the pulse. All right, just to make sure they still have a pulse. But for a rapid trauma assessment, if you're in a hurry, you can stop at the knee. If you make it that far and you don't see any problems with the legs, skip it. You won't fail for that in school, and it will buy you some time in the real world. Once you get done with your extremities, you're going to roll your patient, check their back and their butt for the just same as you did everything else. Make sure that you don't feel any step off the rest of the way down their spine. If you're going to put them on a board, now's the time to do it. Otherwise, you can just roll them back over. Make sure that they're not going to roll onto anything that might puncture them. So if there's a stick on the ground or something, you don't want to do that. All right. Sorry, I know it's a long night, but we will be done before 10. Actually, we should be done much faster than that. We're almost to the end here. Your vital signs, again, you can kind of plug this in anywhere. All right. If you feel like you want to get these first, once you get to your secondary assessment, that's perfectly fine, especially on medical calls, because you can get a lot of information from vitals. Just don't put them up so high that you forget your primary. So like you walk in the room, I tell you what you got, and you're like, all right, and then you go reaching for the blood pressure cuff. That's a no-no. But these devices should never be used to replace your comprehensive assessment of the patient. In other words, treat your patient, not your numbers. Think of these devices as adjuncts to the assessment and treatment of your patient. It gives you a better look as to what's going on inside of the body. So we'll start with pulse ox. That's what you see in the picture. Pulse ox is an assessment tool used to evaluate the effectiveness of oxygenation. Here's the thing about pulse ox, and I'm going to skip the rest of the information on this because it's not that important. These devices only look at the gas that's in your blood. All right, they don't really tell you what is oxygen and what might be something else. So if you show up to a patient and you're thinking carbon monoxide or something like that, you throw a pulse ox on them, they're going to see 100%. You're like, oh, good, they're fine, but they're not. That's the carbon monoxide in their system. All that thing does is says, hey, there's gas here in the blood. Doesn't know if it's oxygen or not. So I'll harp on it. Treat your patient, not your numbers. If your patient looks hypoxic, but that thing says 100%, give them oxygen. The downside is you don't know if you're over oxygenating them. The upside is if it is carbon monoxide, it really doesn't matter. You need to over oxygenate them. You need to do something to push that carbon monoxide out. All right. Some things that might mess up your pulse ox: cold fingers, lack of blood flow, fingernail polish, things like that will affect your reading. So if you put this on somebody with bright red nails, you're not going to get a good reading. Capnography is measuring the opposite. So when we do capnography, we're looking at their exhale. All right, so we're monitoring their CO2. And I'm glad they put this in here because capnography is technically a paramedic skill. And I think that is BS. It should not be. The only reason that it is because you have to be an advanced provider to operate the monitor, and that's how they measure their capnog. But knowing what capnography is and knowing some certain numbers, some variables with it can really help you in a lot of things like, say, CPR. If you're watching capnography during CPR, you should have, if you're getting good compressions, you should have at least 10 on the capnography. If you're, let's say you see a paramedic stick a tube down somebody's throat, or you as an EMT puts an LMA down somebody's throat, and you give a breath, if you've got capnography on there and you get 0 for capnography, that tells you that you're in the stomach. Or for whatever reason, the air is not going into their lungs, it's going into their stomach. So it's very useful. Blood glucose is measuring the level of glucose in the bloodstream. This is a non-invasive blood pressure cuff. All right. If you ever see it on the monitor, it says NIBP. That's what it stands for, as non-invasive. You're not actually breaking the skin. You're not putting anything into the artery and having it measured there like a PICC line would or something like that. This is just an outside of the body way of measuring. It's not exactly 100% accurate. So even on a monitor, the numbers may not be exact, but they're close enough for us to make good decisions off of. And then reassessment. Now, the only thing that I want to say about reassessment, we're going to call it a night, is if they, remember we talked about it earlier, if they're unstable, how often are we going to reassess?
5 minutes.
Every 5 minutes. If they're stable, say they just stub their toe.
15.
15, good. All right, now here's what we reassess. Okay, you don't have to do your entire assessment all over again. You want to reassess your primary assessment, make sure that any of, especially if you did an intervention, say like a tourniquet, if you're having to bag them, which is where you're using a BVM and you're breathing for them, any of those you reassess, make sure that nothing has stopped working. All right, you reassess your vital signs, and you reassess the patient, your general impression of the patient, to make sure that they are hopefully at least staying the same. They may not be getting better. Not everybody's going to get better in your truck, but we want to hope that we're at least stabilizing them. So that's what we're reassessing for. Reassessment is easy. It's also a good time to talk to your patient, see how they feel. All right, reassess their pain scale. A lot of the questions you got in your patient history are not going to change. So you don't have to ask them repeat questions, but some things are nice, right? How's your pain? Is it better or worse? A lot of times, if you can stabilize a bone, it lowers their pain, especially if it's, say, like a midline femur fracture. You get that stabilized and you'll see them actually like take a sigh of relief. So, it doesn't even really take pain meds to get them there. That's going to be the real big thing that you do with that. And then that's pretty much it. So reassess your chief complaint, recheck your interventions, and identify and treat changes in the patient's condition. Like I said, if there's something's not working, then readjust your approach. Okay. Any questions on tonight? Interesting. Put that into the Facebook group. That's that. I'm going to look into that, but that may be something cool for your classmates too. So Tamara just sent a message, said there's a show called Night Watch Nation where they show how they assess with the calls and them on the scene. They do a good job with that. Apparently, I'm going to have to watch it and see. But I'm going to be getting your pen built here real quick. If there aren't any other questions, then we will call it a night. We are going to harp on this. It's going to be kind of like anatomy. You're going to get a little bit of this every night we have class, at least once a week. I'm going to pop in an assessment question and see how you guys are doing. So tonight's pin, let me see. All right, tonight's pin is going to be B as in Bravo, C as in Charlie, the number 9, P is in Papa, and A is in Alpha. So let me type that if I can. I think it's kind of screwy with me typing. BC9PA. There you go. All right. Not bad for getting it all in one night. What is today? Tuesday? We will resume on Thursday. We'll continue up. So, like I said, 2-week extension on your module 1. So try not to fall behind on that. I know some of you haven't taken any tests yet. If you know, if that's you and you're in the class, get into Canvas and get caught up. If you need me for something, let me know. Yeah, please don't. Those pictures look pretty gnarly. So, all right, I'm going to kill the recording now. Y'all have a